you to the opening symposium, which opens a project of the International Agency for Atomic Energy. Let us wait for another 2 minutes before we commence the symposium.
Good morning to all English-speaking participants. I welcome you on the opening meeting of IAEA TC project POL9027, enhancing the capabilities of positron emission tomography departments to provide high-quality imaging and therapies to promote safety culture. All of you speaking in English, please take into consideration to use Vimeo platform to follow all discussion in English language. I mean, if someone will talk in English, it will be in original voice, but when we will talk in Polish, it will be translated simultaneously into English. You see on this screen on the right side the link to Vimeo platform with English translation. Thank you very much, and please switch to Vimeo platform and stay on Click Meeting also. Only mute your speakers for Click Meeting.
Ladies and gentlemen, now I would like to welcome our guests. Chciałbym powitać naszych gości.
Tomo Furosowa.
Hi, good morning, everyone. I hope you can hear me well.
Yes, please go ahead.
Okay, yes. Yeah, so good morning, everyone, and thank you for the opportunity, and also thank you for the participants joining this meeting. And I'd like to thank the organizer, Darius and Piotr, great, excellent organization of this meeting, as always. And so as introduced by Darius and Piotr, my name is Tomoko Furusawa. I'm a Program Management Officer at Division for Europe and Department of Technical Cooperation at IAEA. And I closely work with my colleague, Ms. Manley, and the Technical Officer, Peter Knoll, and Ms. Jenia Vasileva. So with this project team, we support the project implementation of POL9027. This is a successor project POL9025, and I see the project teams are more or less same. So I am very confident that you can achieve the project objective and project outcome in a timely manner. So I wish you all a fruitful and successful deliberation for the next 2 days. Thank you.
Thank you very much, Tomo. I hope that you stay with us and we follow the meeting. And I'm looking on the list who is logged in today. Just a moment. Okay, so just follow the list. There are not at this moment with us some additional guests from Atomic Energy Agency. I mean, Peter Knoll. I am sure that he will be joining us very soon. He is a technical officer, nuclear medicine and nuclear medicine expert from agency. Zhenya Vasileva, who is officer from radiation protection and Department of Nuclear Safety and Security. We changed to Polish now because I would like to welcome our Polish guests now. a ja nie widzę w tej chwili
I cannot see Director Dariusz Poznański, but I'm sure that he will join us soon. Director Dariusz Poznański is the director of the Public Health Department at the Ministry of Health. I am now looking at the list of participants. I would also like to welcome a representative of the Chief Sanitary Inspector, Director Maciej Ratajczyk, who is the Deputy Director of the Department for Hygiene and Environment. So, Director, would you like to give an opening remark? If not, let's proceed. Would any of the participants would like to contribute at this stage of our meeting? Please either raise your hand or please write us a message in the chat box. Well, I will proceed. First of all, I would like to thank you for attending the meeting. I would like to remind you that we have a range of guests who are using the Vimeo platform. So thank you to all the participants of the meeting. And now I would like to discuss the project, which is the objective of the meeting. So I would like to talk briefly about the POL9027 project. This is a project that will last 3 years. It starts in 2022 and it's entitled Enhancing the Capabilities of Positron Emission Tomography Departments to Provide High Quality Imaging and Therapies to Promote Safety Culture. This is a project which is a follow-up of the previous project implemented between 2020 and 2021. That is the project that was completed at the end of the last year. That was a project that addressed similar issues, but it was addressed to nuclear medicine departments. It was also focused on the quality and assurance and quality control. And the previous project, well, and this project, the current project will last 3 years. It will be implemented between 2020 to 2024, and it will be mainly focused on positron emission tomography devices. When it comes to the previous project, we need to show the relationship between these two projects. As you can see in the screen, the previous project actually provided some statistics. All the materials for the POL9025 project and the project POL9027. All the materials are recorded and they will be available in the future. In future, after the completion of the conference, the materials will be available through the platform. You can find the link to the platform, and the materials for the previous projects are usually in English, and all these materials actually contain subtitles in Polish. So if you have not seen the materials, please review them. The statistics are quite interesting. We can say that this area is quite hermetic. Please take a look you can see that the number of YouTube viewers of the opening symposium and other events, the closing event, well, there were over 100 participants of each event. So it's quite impressive when it comes to the implementation of this project. What are the objectives of this project? As you can see, this is the optimization of exposure. We do not have to discuss it. Ionizing radiation during radiotherapy is the target in itself. When we are using ionizing radiation techniques and practices, these are the techniques that actually cause some exposure to patients to some agents. So we have to deliver quality assurance and quality control to ensure that the methods are safe for the patients. I would like to emphasize one more aspect. I find it incredible that within the past few years, a dozen years or so, development of nuclear medicine technology is just amazing. So there are lots of innovations that are being introduced all the time in the field of nuclear medicine. So the quality control and quality assurance is very important to make sure that these procedures are in line with the modern requirements. Another objective of the project is to improve capabilities of nuclear medicine departments in the field of quality control and quality assurance, also in the field of hybrid methods. So it's not only for medicine, nuclear medicine, it's also for such areas as X-ray diagnostics or magnetic resonance technology. Under this project, we also envisage an option of delivering some training for selected physicists who deal with the quality assurance and quality control. And we will try to select the top nuclear medicine centers throughout the world to be involved in this project. We are also planning to purchase some quality control equipment. So this will be delivered under this project. Once the details have been arranged, and then we will make some purchases of such equipment. A very important aspect which is included in all the symposium meetings and conferences on nuclear medicine. This is the patient dosimetry, individualized, personalized dosimetry for patients. So I hope that under this project you will be able to receive very interesting information, and you will be able to receive interesting resources. Training opportunities. So first of all, the project will fund different types of conferences, missions of the experts of the International Atomic Energy Agency. So this will be either persons employed by the agency or who will be invited by the agency to deliver their speeches, to tell us about some findings. So these people will provide contents to the project. Another opportunity is the practical training in terms of quality control. We are working on this, and I hope that you will receive some tangible benefits. We are also planning depending on the situation. We don't know how the future will evolve. The pandemic is coming to the end, but some other issues are very active now. Still, we are planning to fund some scientific visits for some of you. So the visits will be to the leading nuclear medicine units, and we will also finance or co-finance different types of speeches delivered during different conferences and events. So, how do we imagine the project during its implementation? If any of you took part in the previous project, you will notice that there are quite a few similarities. So we plan for the project to establish 3 reference centers, which during the project will provide you support in terms of different trainings, and after the project there will be the centers which will provide support to you in terms of the quality control. So this will be the nuclear medicine facilities in Bydgoszcz, Warsaw and Wrocław. We are planning also to deliver some practical trainings in QA and QC. We will be addressing PET-CT hybrids and PET MRE. We are planning, and I do hope that soon after our today's symposium, we will deliver a survey concerning patient exposure during PET-CT procedures. Of course, we will be stressing the importance of the radiological radiation protection of the patients. After the survey, after receiving the results, we will see whether the project requires some changes, whether the approach has actually changed as a result of the project. We are also envisaging some purchases. We will buy equipment used for the purpose of various training and tests. So we will purchase Yaszczak phantoms, NEMA body phantoms, and all kinds of accessories. And the purchases will be agreed with the leading centers. And also we are planning to buy a portable contamination monitor. Who is involved in this project? All the nuclear medicine departments which are equipped with PET equipment. International Atomic Energy Agency, of course, is involved in the project, as well as the Polish Atomic Energy Agency, the Ministry of Health, the Minister of Health. We cooperate closely with the Polish Society of Nuclear Medicine, with the National Consultant in Nuclear Medicine, and we are present. We work on the project. We did the project. That is the National Center for Radiation Protection in Healthcare. Ladies and gentlemen, now the last slide of this presentation, which shows the project budget. So we are looking at the amount of over €500,000. this funding, some of the funding will be spent by Polish entities. All the procurement, different trips which will involve the project will be funded by the International Atomic Energy Agency. I would like to attract your attention to this amount, which is a really huge amount, and it's for 2022. We are looking at over 100 euros, 2023 over 400,000, 2024 it's half a million. So thank you very much for listening to this summary of project POL9027. Would anyone like to contribute some remarks, some questions at this stage? If yes, please raise your hand or send us a message. If there are no questions, now we will proceed with the speech by John Dixon. Witam Cię, Johnie, bardzo miło Cię znowu.
This is an expert, agency expert who was involved in the previous project also. And today, just a moment, today I would like to invite John Dixon, who is head of nuclear medicine physics on University College London Hospitals. And he will be asked for presentation on quantification of PET and SPECT data. John, the screen is yours.
Thank you. And can you see my screen okay now? Is that clear for you?
Yes, okay.
Okay, thank you. So yeah, thank you for the invite, and you know, I'm really excited to be giving this talk for you today on the quantification of PET and SPECT data. And really what I'm going to focus on is how we acquire good quality quantitative data for both PET and SPECT. Before we go into the details, I just want to have a little bit of thought on what we're trying to achieve. And we know that nuclear medicine is all about the radiopharmaceutical, where we have our pharmaceutical, which is a compound that targets a particular physiological process. And if we radio label that, we can use the radiopharmaceutical for therapy and diagnosis. So of course, if we have this radiopharmaceutical that's mapping the physiological process, it would be nice to quantify what's going on in vivo. But before we get there, we think about what we're doing in nuclear medicine today. Of course, a lot of our imaging is based purely on visual interpretation. And you know, just to show up this example here of ioflupine SPECT or DAT scan, you know, we can quite easily look at images like this and look at the absence of radiopharmaceutical uptake in striatal structures to help us give diagnoses of, for example, Parkinson's disease. Or in this PET example, gallium-68 PSMA PET-CT, you know, with visual interpretation, we can obviously look at the extent of the primary tumor, but we can also look at the you know, the extent, see if there's any metastatic spread, or to see if there's involvement of the lymphatic system. But here, really, what we're looking at is just a binary situation. We want to look to see if there's uptake or no uptake. And that's okay for many applications. That's fine. But we can go a little bit further, and indeed we do. And, you know, we know that if we're looking at myocardial perfusion SPECT, we are looking at the relative perfusion in the myocardium. So we look at the maximum uptake, and then we look at the relative uptake compared to that maximum in the myocardium, and we can look on slice data, or we can look on bullseye plots, and we can represent the uptake in various regions as a percentage of the maximum. So this is looking at relative uptake. And similarly with FDG PET in the brain, for example, many of our brain PET examples, we might want to look at the uptake in the cerebral cortex and reference that to the uptake in an area such as the cerebellum. And this kind of relative quantification, I'd like to call semi-quantification. But, sometimes we want to do more. As I mentioned earlier on, we have this radiopharmaceutical, we can map these physiological processes, and we want to quantify these physiological processes to try and get an idea of disease progression or disease, the strength of disease, for example. And we've been doing this for many, many years, right from the start of nuclear medicine, where we would be looking at uptake of our radiopharmaceutical in the thyroid to get an understanding of the, the metabolism in the thyroid. Is the patient hyperthyroid or hypothyroid? And we could do this by quantifying uptake in the thyroid. And from then, with the start of PET imaging, we were quantifying things like neurotransmitters and neuroreceptors within the brain to understand the physiological processes in the brain. And more recently, of course, where PET has moved into oncological applications, we've looked at things like SUV, where we're quantifying the uptake in regions and accounting for the amount of activity we've injected into the patient and the size of the patient. And this, of course, is also happening now in SPECT as well. And finally, the last area of quantitative nuclear medicine that is becoming important to us is dosimetry following molecular radiotherapy or radiopharmaceutical therapy, where we want to look at the activity concentration in organs at risk or tumors over a period of time, so we can look at the energy imparted into the tumor to try and get an idea of how much radiation, how much treatment we've given to the patient. Okay, so after the introduction, let's look at how we get good quality SPECT and PET data for quantification. I've called this tips and tricks. I think what we've got to consider is we've got to remember that we've got to look at every part of the imaging chain if we want to quantify our imaging. Some of our energies we'll need to put a lot of energy into getting things right. Sometimes it's less hard work to do. But let's look at the imaging chain from patient preparation right through to analysis to see what we should be doing to make sure we get the best quantitative data that we can. And what I'm going to do as an example to carry through some of our presentation this morning is I'm going to focus on FDG PET. I will branch out into other imaging investigations as well, but I think FDG PET is one that is relatively well known and we can relate to. So we know that when we're doing FDG PET, we inject our FDG, which goes into the blood plasma, and from the blood plasma, the FDG can go into tissue, and indeed it can come out of tissue. And we know that some of the FDG that we might have in tissue can be metabolized, and potentially it could also leave that metabolized state as well. So what we're looking at here is the kinetic model of FDG. We're looking at what's happening, trying to characterize what is happening to FDG within the body. Now, this is just one kinetic model, and there are other kinetic models for different radiopharmaceuticals, and we'll look a little bit at some of this later on. So then we've got to consider, looking at the image chain and maybe focusing on FDG. How do we need to prepare our patient to get good quantification? Well, remember, what we're trying to do with our quantification is quantify a physiological process. So, for example, in this case, we'll concentrate on FDG metabolism in tissue. But if we want to look at that physiological process, we've got to restrict any competitive processes. Now, that could be interactions with other drugs, or in the case with FDG, competition with non-radioactive substances such as dietary sugar. So we know that, for example, if we have a patient who has high blood sugar and we inject them with FDG, there's going to be competition in the tissue with whether the tissue uptakes the non-radioactive blood sugar or the radioactive blood sugar that we're trying to use for imaging. So in terms of FDG, we need to prepare our patient appropriately. We need to get them to fast to reduce their in vivo blood sugar levels prior to injection of FDG so that we can get the best quality uptake of the FDG in our patients. So if we don't do this, it will affect the quantification and, of course, also the image quality. So patient preparation for FDG and for some other radiopharmaceuticals is something that we should be considering. And in fact, I've got another example for iaflupane SPECT, so the brain image I showed earlier on, which we use to differentiate between Parkinson's disease and essential tremor, or Lewy body dementia and Alzheimer's disease. And we know for this particular radiopharmaceutical that medications will affect or can affect visual assessment and also quantification. So what do? We know that our neurological patients are on a whole host of medications. So we can either see if it's feasible to take our patient off some of these medications that would affect our imaging, or we would need to have knowledge of the patient medications so that when we're interpreting the image, we can account for the medications that the patient is taking. So this is just an example of some of the medications and drugs of abuse, indeed, which can influence the iaflupane uptake. This is from Jan Boy in 2007. And I guess the thing here is, we are talking about drugs of abuse as well. You might know what prescriptive medicines people are on, but also be aware that some drugs of abuse, such as cocaine, would affect the uptake of this particular radiopharmaceutical. Okay, patient injection isn't really too much of an issue when we're doing quantitative imaging. If we're doing full kinetic modeling, pharmacokinetic quantification, we ideally want a bolus injection. There are some times where you might need to be a bit more complex in your injection. You might need a constant infusion, but these applications are really rare. Most times we're giving a bolus injection. And we find that for most, particularly clinical imaging, a 3 to 5 second injection is acceptable for our radiopharmaceutical. And really that's to avoid any reactions that there may be to the radiopharmaceutical, also for ease of injection. What I would say at this point, and I'm going to say this many times through this presentation, is for quantitative imaging, it is important to know how much activity is injected into the patient. We need to know how many megabecquerels of FDG or iaflupane or HDP we're injecting into the patient. Because quantification often requires the knowledge of the injected activity. And what we will do with our scanner is we will often calibrate our scanner against the new radionuclide calibrator that we're measuring the activity for our injections with. We can calibrate our scanner so that the scanner is measuring activity rather than counts. So we need to have a good knowledge of our injected activity. We need to have a good radionuclide calibrator, and we've got to make sure that radionuclide calibrator is having appropriate quality control, including checks on the accuracy of the device. Okay, I mentioned about time of imaging in our imaging chain, and this is really important. I'm going to focus on FDG to start with, and what you can see in this chart is that the uptake of FDG in blood pool, which is shown in red, or in malignant or inflamed tissue in green and blue, you can see how the uptake changes over time. So this means, for example, if we were doing an FDG PET at 60 minutes after injection, we'd get one value for our quantification. But if we imaged at 90 minutes, we'd get a completely different value for our quantification. So you really have to be consistent with the timing that you're using, particularly if you're doing longitudinal measurements. I think even if you're just doing, a single time point measurement, if you're wanting to measure something like SUV and you're relating it to some guideline where it says the SUV should be over 5, you should be at a standard time point. If you're doing multiple longitudinal imaging to look at disease progression, you need to be consistent with the time that you're quantifying your uptake. Otherwise, the differences will be purely to the time of imaging, or could be affected by the time of imaging. And here's just a visual example which shows an FDG image 1 hour, 2 and 3 hours post-injection. And you can see how the uptake in the tumor shown by the red arrow changes. You can also see how the contrast is changing. The background in the soft tissue is also changing too over time. And I was saying this is not just for FDG, this is for all, or not all, many radiopharmaceuticals. If we're quantifying, we really should be aware of the time of imaging, getting it right and being consistent. So these are 2 PET tracers here just because the time activity curve information is more available, but we know again for things like IO-fluoropane spec, the quantification will change depending on the time you image. Okay, during the uptake period, we don't need to do an awful lot, but sometimes we do. For example, with FDG, we know that with FDG, it is important to manage the patient during any uptake period because, for example, if we were doing brain imaging with FDG, if we give the patient visual or auditory stimulation, we're going to get uptake in the visual and auditory cortex. So if you're trying to quantify uptake in these particular regions, it's important to avoid visual and auditory stimulation by keeping the patient, in a quiet and darkened room. But we also know that if we're doing oncology PET, we've got to avoid muscle stimulation because uptake in muscles can reduce contrast or give us false readings. So for example, this is a patient who was chewing gum and we see uptake in the jaw muscles, or a patient who was weight bearing after injection but before imaging, and you can see the uptake in the lower legs here. And these examples are actually taken from a very nice paper from the Journal of Nuclear Medicine Technology. So for many radiopharmaceuticals, we don't need to be concerned about this, but if you are quantifying, be aware or do a little bit of work to see if you need to manage the patient during the uptake period. So we've injected our patient, we've left them the appropriate time and we've managed them, and then we need to obviously collect the data on our scanners. And if we look at data acquisition, we have a compromise. Life's about compromise, huh? So the compromise is between the spatial sampling or the voxel size that we might want to have in our quantitative image, and the noise in the images that we're going to acquire. So let me explain a little bit more about this. This is for both PET and SPECT. So if we, when we're setting up our scanners, we can choose the size of our pixels or voxels. And really what we should be choosing is that if we want to properly represent a feature, we really should be taking a voxel size which is at most half of the spatial resolution of the system. So for example, if we had a system with a spatial resolution of 4 millimeters, the voxel or pixel size should be less than 2 millimeters. So let me try and explain this just with this figure. So if we have the black line, which represents our uptake, if you see the orange bars represent a small voxel size, and you can see with that small voxel size, we represent the uptake quite well. But if you look at the two blue squares, what I've done here is gone to a complete extreme and taken a very large voxel size. And what happens now if we have this large voxel size, not only do we not represent the full activity in the feature, but we also spread out. We make the feature look a little larger as well. So it's really important to get the appropriate size voxel. And now you might be thinking, well, I just should always take a small voxel size, because if I do that, then I'll always get the appropriate sampling. But we can't do that because if we have less counts per pixel or per voxel, we get more noise. So if you look at these two images at the top right here, where we've got a 440 matrix or a 1:8 matrix, you can see with the 440 matrix, we can see features are better defined in the lungs, in the ribs, in the neck region. But we can also see with this smaller, with more voxels or a smaller voxel size, the data looks noisier. So what do we do? Well, we could filter our data. We could choose to use larger volumes of interest when we're trying to measure our uptake. Or sometimes what people will do is they'll do two reconstructions. They'll do one reconstruction which the doctor is happy to report, so they can kind of assess the the features. But if you're doing quantitative measurements, then we can do something that's a little bit noisier and maybe something that's a little bit harder for the doctor to interpret, but will give us more accurate quantitative values. Okay, in terms of SPECT and PET reconstruction, we've got our projection data, we've acquired our data, we need to reconstruct it to get the 3D data. So we should always use iterative methods, such as OSEM, because things like filtered back projection are not as good for applying corrections. And we'll come on to what these corrections might be later on. So the takeaway is you should be using iterative methods. But what happens with an iterative method, if you remember, is you make multiple estimates to try and get an image that best matches the data you've acquired. So it's an iterative process. You keep on going through until you get an answer that is a good answer. But to do this, you've got to do sufficient iterations to get to the correct answer. If you do insufficient iterations, if you have not enough guesses to try and get the right answer, you won't get the right answer. So if I show this example here, this is just looking at a brain scan, and we can see the striatal structure. So you can see what happens as we increase the number of iterations in our reconstruction. We better define the striata within the brain, but you can see that we're getting more noise in the image. So if we increase the iterations, we get a better answer, but we may need to apply some smoothing to try and reduce the noise a little bit. And in terms of corrections in PET, so what are the corrections that we're applying in the reconstruction? What happens when we are acquiring PET or SPECT data? We have physical processes such as attenuation of our photons or scatter of our photons that worsens the image quality, degrades the image quality. So we need to correct for these degrading processes. And in PET, most corrections are applied by default, so attenuation correction, scatter correction, dead time correction. And if you have them, you should also use time of flight if your scanner is capable of time of flight PET, because it offers better localization and better signal to noise. And you should also apply resolution modeling if that's available on your scanner, because it provides you with sharper images. It recovers the resolution losses. It gives you a higher uptake when there should be a higher uptake. In SPECT, things are a little bit different in that the choice is there, but you can choose which corrections to apply. They're not really all, by default, you could choose to apply no corrections on most SPECT scanners. But really, you should be using all the corrections that are available to you, such as attenuation correction, scatter, resolution modeling, and dead time if you're doing dosimetry measurements. What I should say about attenuation correction, you could or you may have an option to use a Chang attenuation correction, which is not measured, it's calculated. But really, if you're doing quantitative imaging, you really should be applying CT attenuation correction to your data. So, each correction will affect the quantitative values that you get from your data. So whatever you do, please be consistent, because then your values will be comparable to repeat scans or other patients that you're scanning. Okay, I'm going to mention the scanner calibration here. I think I'll mention it again later on. So when we have our PET and our SPECT scanners, the native data we get from the image in the images is number of counts, the number of detected events that we have in our detector. But that isn't helpful. We really want to know the activity that we've got in a voxel or the activity we've got in a region of interest. So, for example, if we have an FDG patient, we'll measure the activity in our radionuclide calibrator before injecting. So we might, for example, inject 400 megabecquerels of FDG. And then what we want to do typically in quantitative imaging is we want to measure the uptake in the patient in terms of kilobecquerels or similar, could be SUV. So we need to calibrate the scanner so that we're not measuring counts, we're measuring activity. And we need to link that measurement to the radionuclide calibrator that we measured when we were measuring the activity we injected into the patient. So, typically if you do these calibrations in PET scanners, you create a calibration and it will automatically be applied. For more modern SPECT systems, you have a similar thing, but if you're using a more traditional SPECT scanner, you may need to use an imaging standard, but we'll come on to that a little bit later on. The key thing is, and the reason I brought it up here is, when you're doing these calibrations, you should use the same parameters that you're using for clinical imaging, because what you're wanting to do is you're wanting to do this conversion of counts to activity with the same conditions as you would be when you're imaging your patients. Okay. So let's now we've got our image data and we want to analyze it. So let's look at what options are available to us and choices we could make. So I'm afraid I'm going to start off with the slightly trickier stuff and start with kinetic modeling, because if we're thinking about looking at physiological processes, then we've got to look at how the radiopharmaceutical moves into tissue and out of tissue, and that is what we're looking at with kinetic modeling. So what we're doing is we're quantifying the kinetics of the radiopharmaceutical. And the way we do this is that if we know what we've given the patient, so if we're looking at the influx of the radiopharmaceutical, so if we've given our bolus of radiopharmaceutical, that's what we're giving to the tissue, and we measure that typically from blood plasma, which is our input function. And then what we then do is look at various tissues and look at the relationship between what we gave the tissues and how the tissues responded to it. So we can derive the kinetics of the radiopharmaceutical in organs and tissues. And we do this using compartmental modeling. So what is compartmental modeling? Well, we mentioned this a little bit when we were looking at FDG earlier on. So compartments are different versions of the radiopharmaceutical in a physical space. So if you remember previously, we had, the FDG could be in tissue, and it could either be metabolized in tissue or just free in tissue. So that would be two compartments, either metabolized or not metabolized. And what we then have is we'll have, we can derive values that represents the movement of the radiopharmaceutical in and out of these compartments. And we typically also look at the concentration in the plasma. So, what we started off with, we look at the activity concentration in the plasma, but also in various tissue compartments as well. And we can have any number of compartments. And this looks a little bit scary on the right here. But if you look at that 2-compartment model, the one in the middle there, you see it's what we had for FDG, where we have the radiopharmaceutical in the plasma. It can move into tissue, which would be compartment 1. It can move and be metabolized in tissue, and it can obviously move the other way as well. But there are other models. You can have a 1 tissue compartment model, or 3, or there's any degrees of complexity. The other thing to be aware of is with these compartments is that they can be reversible, which means that the radiopharmaceutical can go into them and leave them, or they can be irreversible, which means once the radiopharmaceutical has gone into the compartment, it stays. So, and if you remember with FDG, we were kind of saying, well, when it goes in, it metabolizes, and if we hope that none of it comes out, then we can get an idea of FDG metabolism. So how do we do this compartment modeling? Well, we have to acquire a dynamic, time varying, a time series, PET, or typically PET, it could be SPECT data series. And we'll draw volumes of interest around our tissue. We typically get the plasma data from arterial blood, but there are other options. And we can solve some mathematical equations to work out, characterize how the radiopharmaceutical is moving between the various compartments. Now, you wouldn't do this much in clinical imaging, but there are applications out there in the clinical department which are using compartment modeling or kinetic modeling. So the first of which is a relatively simple example, is using rubidium PET to look at myocardial blood flow. So what happens in traditional myocardial perfusion SPECT, what we're doing is we are, we look at this relative flow. We look at the maximum, and then we relate the uptake to the maximum flow in the myocardium, which can give you an issue if all of the uptake in the myocardium is reduced, so-called triple vessel disease. And you also get issues if you're trying to look at small issues with blood flow. So what we can do with rubidium PET is we can calculate using compartment modeling the absolute blood flow. So we can get voxel values or regional values in milliliters of blood per gram per min, looking at the perfusion. So how do we do this? We acquire the data, the dynamic data series. We use the 1-2-sheet compartment modeling, and that's what I'm showing here. So plasma going into tissue. And we actually get the input function by drawing a volume of interest in the aorta or in the left ventricle. So we're not taking arterial blood samples. We're getting the input function directly from the image. And we can draw volumes of interest in the myocardium to calculate the K1 or to get the data. So we can calculate the K1, and then so K1 is looking at the flow from the plasma into the tissue. And there's conversion factors for K1 into blood flow. So we can get images like this where we're actually looking at, if you look in the middle on the right here, we're actually getting absolute blood flow measurements for stress and rest. Okay, but this is a bit tricky, compartment modeling generally, because it requires an understanding of how many compartments you've got, and the maths can be a bit tricky at times. And many of those K parameters aren't really important or clinically relevant. So we have graphical methods available to us, and which requires no understanding of models. It's relatively simple, and it can provide useful parameters such as the influx rate of the radiopharmaceutical. And there's 2 graphical methods out there. There's the PATLAC, which requires there to be an irreversible trapping of trace hairs somewhere in the model, or Logan, which is a reversible model graphical method. And these PATLAC methods are starting to be used in clinical practice, and we'll come on to that shortly. So the PATLAC method, and I apologize for this equation, really what we're doing is plotting the activity in our region divided by the plasma activity at any given time against the integral of the input function that we have divided by the plasma activity again at time t. And if you look at the form of this equation, we have a y equals mx plus c. So what you find is you have eventually you'll have a linear relationship, and this k value represents the influx of your radiopharmaceutical into the irreversible compartment. And the V represents the distribution volume of the reversible compartment, which isn't particularly helpful. And the reason I'm mentioning this is you might be aware that certain PET scanners now allow you to do this whole body PATLAC imaging. So what you'll do is you'll acquire a dynamic scan over the chest for a few minutes, and you start the imaging at the time of injection. And that chest image or the image over the heart will give us the input function. So we can look at the flow of the radiopharmaceutical into the heart and out of the heart, and we can get an idea of the concentration of FDG in plasma over time. And we'll do multiple whole body sweeps over to get the time activity curves in tissue. And it typically takes about 60 to 70 minutes. And you're thinking, well, why would we do this? Because that's a lot of imaging to be scanning a patient for 60 to 70 minutes. Well, the advantages are becoming clearer. They're still not fully developed yet. But one advantage is that the measurements you get don't depend on the time of imaging. So if you image, we said about with traditional PET scanning, if you image at 60 minutes or 90 minutes, the answers are different. With PATLAC imaging, that's not an issue. You do get better contrast in areas like the liver with FDG, but as I said, it requires a lot of imaging. So just to show you here, we have the time activity curves, and this is our PATLAC plots. So you can see we have linear regions, linear parts of it, which allow us to get this K value, which is related to MR FDG, which you see in the bottom middle panel. So you can see the uptake in the liver is a little less with this MR FDG, with this PATLAC approach. And you'll also see in the axilla, where if you look at the left image in the SUV data, it looks as though there's an axilla lymph node. You can see in the PATLAC, the MR FDG image in the middle, that lymph node isn't active, which would suggest that it's more of a, it's not really a metabolic feature to be concerned about. Okay. So we know this is all kinetic modeling and this is all lovely, but actually what we actually use is SUV. So let's look at SUV briefly. Because we know kinetic modeling is challenging, as you've just seen, we may need arterial lines for input functions. But with FDG, where we use SUV the most, we can make some assumptions that if we wait up to 60 minutes, the K4, the movement of the metabolized FDG back into tissue being unmetabolized is really is negligible. And equally, at around 60 minutes and beyond, we also know that the amount of activity in tissues that isn't metabolized is negligible, which means that if we just draw a region of interest, we can say that we're actually looking at that C metabolized FDG is that we can measure with a volume of interest is related to the glucose metabolism. And although SUVs mainly used for FDG, it can be used in other PET and SPECT applications as well. And we just have to remember that we've got to assume a negligible K4, and we've got to assume that at the time point we're imaging, there's no untrapped radiopharmaceutical in the feature. And you'll probably know about this very well. What we'll do in practice is we'll draw a region of interest. We get the activity concentration from our calibrated images. We divide by the injected activity and the body habitus, which is typically body weight, but could be lean body mass or body surface area, because we know that FDG doesn't metabolize in fat, so body weight isn't always the best body habitus value to use. Seeing time is pushing on a little bit. So we have our SUV measurement, but then we have an option of whether we want max, mean, or peak. And you can see in this image on the right what they would be. We draw a region of interest. The maximum is the most common value that we're using in clinical practice because it provides the most intense uptake value, or the most aggressive part of the tumor, let's say. But it relies on a single voxel value and therefore is prone to noise. In mean, if we take SUV mean, obviously we're looking at within the average value in that whole region, but we can get issues with low values from the limited spatial resolution of our PET spec systems, which I'll touch on in a few moments. Or we could take SUV peak, which is looking at the highest average in a 1 centimeter cube volume within our tumor. And this is obviously some kind of compromise between max and mean, I should say mean, because we're accounting for the noise, but we're not kind of getting issues with loss of signal because of partial volume effects. Okay, so let's talk about these partial volume effects. So, we know that our PET and SPECT scanners are limited in their spatial resolution, which means it will affect the measurement of uptake in a region. So let's assume that I've got a 10 millimeter lesion and I measure the uptake in that 10 millimeter lesion. So if you look on the graph on the right, if I had a spatial resolution of 3 millimeters, the average uptake I would be measuring in that 10 millimeter lesion would be 90% of the true value. Whereas in SPECT, when we're getting spatial resolutions of about 10 millimeters, now the average value I'm measuring is about 2/3 of the true value. So we should be aware that when we have small lesions and we're trying to quantify uptake in small lesions, we may be underestimating them and quite significantly. So we must consider this. And this is what we call the partial volume effect. You can apply for corrections for partial volume effect, but they're really only available in research settings or possibly for dosimetry as well. I'm noticing time's pushing on, so I'll try to push through here. We can do other uptake measurements using SUV, so we can look at the SUV times by the volume, which gives us total lesion glycolysis, or we can look at metabolic tumor volume, which will kind of give us an idea of the extent of the disease by looking at the sum of the volumes that have an SUV above a certain value. They're primarily used for PET currently, but we could use them in bone spec for looking at, for example, metastatic burden. We could also look at ratio methods of uptake as well. So in our flupain spec, we look at the ratio of uptake in the striatum to a non-specific region, such as the occipital lobe. We mentioned about how in brain PET we can do SUVRs, where we look at the SUV and relate that to a non-affected area, such as the cerebellum. And for some other radiopharmaceuticals, we would also do tumor to blood ratios as well. These are often related to kinetics and can be very important parameters. Okay, I'm not going to talk too much about this because I know the following talk is going to talk about dosimetry, but we know that in dosimetry, we need to, what we want to try and do is determine the energy imparted in tissue. And to do that, we get an idea of the radionuclide and emissions and absorption within the tissue from, for example, from MERD. But we also need to find out the activity concentration in our tissues or organs at risk over time. So activity concentration can be a metric for us as well. And as I said before, we can use a built-in scanner calibration to get a direct measurement of activity concentration. And it's very important that when we do that, we have a very accurate radionuclide calibrator because activity is directly related to the dose. There's two ways of calibrating. We can do this built-in calibration, which is routine for PET and more common for SPECT now, where we will image a phantom with a known amount of activity within it. And based on that, we can make a conversion of counts to activity. Or what's been traditionally used in radiopharmaceutical therapy is to use a standard. It's becoming less common now, but With a standard, we would put a syringe with a known activity in the field of view of our SPECT scan. And when we've done our SPECT, we can then relate the counts in the syringe to the counts in the feature, like the organ or the tumor, and therefore get an idea of the activity. What do I want to talk about here? Okay, so there's other metrics we can get as well, and one of them is Z-scores, where we're looking at the number of standard deviations our uptake is away from a database, a mean of a database. So what we can do is we can look at the regional value, we can compare to our database and represent the uptake as a number of standard deviations away from what we would expect, or the Z-score. So if it's above 2 standard deviations, then we've got a hypo or a hyper affected area. And we can also go further than that and actually put statistics into our imaging as well, which is really quite complex for those of you who like your brain imaging. You can do some wonderful things here looking at the effects of various parameters on disease or on radiopharmaceutical uptake. Okay, and very quickly just go through some examples of how all this fits together. So we know that with FDG oncology, we prepare our patient by fasting them. We have our calibrated scanner. We have the patient in a relaxed environment during their uptake period. We try to be consistent within 10 minutes of the time that we image so that we're consistent for follow-up studies. And we should use consistent imaging and reconstruction parameters. We might consider EARL if we want to be consistent with international findings. We can measure our SUV or our TLG or our MTV. For bone SUV spec, there's no specific patient preparation, but again, we're going to use our calibrated scanner. So we know the activity concentration in our images. There's no specific requirements between injection and imaging, but we've got to scan at a fixed time to ensure consistency and use consistent imaging parameters. And again, we can measure SUV. Total metastatic bone uptake could also be defined. And for dosimetry, we'll keep this very brief. The preparations as what's required for the therapy. Again, we use our calibrated scanner. In this case, it's incredibly important that the calibrated measurement is accurate. Of course, we would scan at the necessary time points to look at the clearance of radiopharmaceutical, and we need to be consistent in the parameters that we're using. We can draw regions of interest, look at the activity concentration for the multiple time points, and put that into, for example, our MERD dose calculations. Okay, thank you for listening, and apologies for being a little over time there. Sorry about that.
John, thank you very much for a very interesting presentation. Pardon? Okay. John, thank you very much for your very interesting presentation on quantification of PETs. It's very impressive for me. A lot of information on the body. The complication of the human body is terrible, let's say. So always you say that something happened, but it's a lot of buts here in your presentation. That's amazing. Okay, have you any question from audience? Please raise your hand and write down on chat the question. We plan that the discussion on all presentation of this day at the end of the day. I mean, it's 1:45 p.m. So, okay, John, thank you very much at this moment, and we are waiting you at the end to the general discussion, and we move to Carlo Chiesa. He is just a moment. He is medical physics expert in nuclear medicine in National Cancer Institute in Milano. Carlo, may I ask you for the presentation how to use nuclear medicine data sets for radiopharmaceutical therapy? The screen is yours.
Thank you so much. Thank you to the organizer, to the agency for having invited me. I now have only to share the screen. I need your your instructions. I think that this.
You succeed for sure.
So I will tell you how to use nuclear medicine data sets to optimize therapy. We have I thought mainly to the most important applications for therapy. There is also other applications that cannot be covered in 40 minutes. But I will speak first of all about the radioactive microspheres to treat the liver neoplasm. Then of the lutetium-labeled molecules against neuroendocrine tumors and prostate cancer. And as last, but maybe not the least and very important, the iodine 131 against metastatic thyroid cancer. First of all, I recall what maybe Manuel Bardies told you the previous meeting that you had. The dosimetry calculation is done in 3 steps. The more common workflow is that you first go for a quantification to obtain an activity in several time points, and then you have a time activity curve. Then you have to integrate this time activity to obtain the cumulated activity, and then you have to do the dose calculation multiplying the cumulative activity times an S factor, which is delivered by codes or tables. A more rare workflow, it is just reverting the last 2 points where you can use the first the dose rate, calculated the dose rate at several time points. And this is important when you have a target mass, a tumor, which decreases its mass in the few days while you are doing the dosimetry. So the S factors is not constant and so cannot be taken out of the integral. And so you first calculate the dose rate and then make the integration. But in any case, you have to do 3 steps, and this will be covered during my presentation in the different examples. So first of all, let's go to the radioembolization. You know that liver tumors can be treated with microspheres, and the reason is that the liver is fed by artery in the tumors, while the normal tissue is fed mainly by the portal vein. So if you inject something in the artery, you can reach more the tumor than the normal tissue, and you can spare the normal tissue. In this way, under angiographic guide, you can inject some radioactive agent to these green balls here and try to destroy them. This is useful because you can inject also something similar to the real therapeutic particles before doing the real treatment. And so you can make a simulation and then a therapy, exactly like you do in the external beam case. About radioembolization, we are lucky because we have 2 recently published guidelines by the European Association of Nuclear Medicine. Here you see the dosimetry guideline that was led by myself, and then you have also the clinical guidelines for, where a lot of physicists also participated. And please note this address, this web address, because it is where you can find all the guidelines published about therapy and dosimetry by the European Association of Nuclear Medicine, and also clinical applications. So when we have liver, what should be contoured? Of course, lesions, and we have to contour on the CT and on the perfused SPECT, and this will be clearer later. We have to contour also non-perfused lesions because we have to compute the total volume of the functional liver. And we can have a lobar treatment with a left lobe lesion that it is not targeted and have to be subtracted in volume from the total volume. And similarly, we have to compute the necrosis volume to be subtracted for the total parenchyma. And we have to contour the whole non-tumoral liver, which is very important for the prediction. And in case we have portal vein thrombosis, we have to contour also this to calculate which is the absorbed dose to this target element. For non-tumoral tissue, it is more reasonable to use the lesion CT volume to exclude the necrotic regions from the calculations. So lesions for the to obtain point, the item number 4 is the also the CT lesions. So we have to contour both in both images. There is a special case where you have infiltrative tumors when the radiologist is not able to define exact border of the tumors, and so you can, an approach is to consider the whole liver as non-tumoral. In this way, you overestimate the dose to non-tumoral liver and induce the therapist to choose a lower activity, so you have a conservative and safer approach that can be applied. But this is still to be clarified from the scientific point of view. Another question is, shall we contour on the SPECT threshold or on the CT? And as I told you, we have to contour both, because the SPECT region it is the best responding, most responding one, but we need also the total lesion volume to be subtracted from the normal liver. So you have to contour both in this yellow void and also in this red void. And here you see the problem that can arise when we make a SPECT and a SPECT CT. You can be in a lucky situation where the CT black void coincide with a yellow SPECT void full of counts, but you can have a necrosis where there is no uptake of radiopharmaceuticals and nor microspheres, and so this should be subtracted from the lesion and from the total liver. But you can have in the panel here C and D, you can have the breathing motion, where very common in SPECT imaging, where the technetium image is shifted with respect to the CT contouring, and you can have also the necrosis shifted from the CT border of the tumor. And for this reason, in the guideline, we proposed the dual void method, which is taking a void on the black circle and taking one void on the yellow region, and take the volume from the black circle and the counts from the yellow region. That is a bit more demanding, but it's useful to have a good countings of the tumors. Another point is in acquisition. What shall we do for the lung shunt? Because the original indication by the manufacturers, they indicate only to scan planar the chest and the abdomen, but this is not enough for modern dosimetry, because you can have a high lung shunt. So we made a workflow where you have 3 possibilities. No lung shunt, no problem. You don't need to scan the lung in the tomo scan. And the activity in the liver is the injected activity. You can have a very low lung shunt, less than 10%. And so in this case, you go for an approximate calculation to estimate the real lung shunt, which is lower than what appears in planar, because in planar you don't have fully corrected images, so you have scatter and you have attenuation that overestimate the real scan, the real lung shunt. But the focus is on high lung shunt in planar scan. In this case, you have to cover with your SPECT and with your post-therapy imaging, you have to cover both lung and liver to calculate accurately the lung dose, because could have a clinical significance. For the absorbed dose calculation, the first hypothesis, which is used by all the authors in the literature, is based on the fact that there is a permanent trapping of microspheres. So you have you have here only microspheres are found in explanted liver for transplantation, even 3 months after the radioembolization. So this is a sort of supporting the idea that microspheres stays forever where they lodged at the initial therapy injection. So if there is no biological clearance, this is a very convenient situation, because we have only physical half-life decay of the yttrium in the liver, and the integration is quite well known by physicists. It is this integral which is equal to the activity in a void divided by the decay constant of yttrium-90, so the value is quite easily computed, and the dose is given by this expression here, where we can group together these factors here, and we reach the final formula to have the dose in a volume of interest, which is a constant times the activity in that void divided by the mass of that void, and these two have to be determined in your acquisition. So one tomographic scan is enough. So it's an enormous advantage for doing dosimetry with respect to radiopharmaceuticals. The second hypothesis is that in the therapy, you have the same biodistribution that you have in the simulation with macroaggregates. And this here you have plenty of publications showing that this is a sort of a weak point, because the true dosimetry really doesn't match so well in any specific patient. For this reason, it's extremely important to do a peritherapy imaging and dosimetry, and the suggested method is, of course, the yttrium-90 PET. You could use also yttrium-90 SPECT, Bremsstrahlung SPECT, but Bremsstrahlung is really very difficult to be quantified accurately, because you don't have a peak, you don't have corrections in Bremsstrahlung imaging. So only research centers have software to perform a good quantification on Bremsstrahlung, and for this reason, yttrium-90 PET is suggested. This correspondence between simulation and therapy fails macroscopically on lung, as you can see in these pictures here. In gray, you have the technetium distribution, and in color, this white is the real macroaggregate, the real therapeutic distribution. And you see that in lung is visible in the technetium, in the simulation, but it is not visible in the therapy imaging, because the point is that macro aggregate are not of a fixed size like the therapeutic particles. And the macro aggregates, they have a small fraction, very small, 10 micron size, that can escape to lung much more easily than microspheres. And so you have a false lung shunt in the prediction, which can cause troubles in the dosimetric prediction. But on this way, we must compute the lung shunt, because it's indicated, and because the lung it's an organ at risk, and so we have anyhow to compute the lung shunt from planar, for instance, just drawing the ROIs in this way, and computing a simple fraction of lung counts divided by the total counts, and then making the geometric mean into planar conjugate view technique. This should be overcome when you have a large lung shunt, making a tomographic evaluation by contouring the tomo on the 3D images. And this is another point, which is what happens in the liver comparing the dose calculated in the simulation and the dose calculated in the therapy session. And here you see the blind outcome analysis, which is very simple. Each black point, his dot here, represents in the vertical axis is the difference between the dose calculated with the real therapy minus the dose calculated in the predictions. And we computed this in two kind of patient. Patient injected on the first week of the glass microspheres, when you use few spheres per gigabecquerel, and it is the left of this figure, and when you use many spheres, if you inject a patient in the second week, when you use 3 times more microspheres per gigabecquerel, because they are decayed and the specific activity is much higher. And you see, anyhow, in both cases, that for lesion, the difference, and this red horizontal lines represents the 95% coincidence interval. So 2 sigma up and down for the differences. You can have differences up to about 300 grays difference between the predictions and the real therapy. Of course, this is only for 2 sigma, so it's 1 patient over 20 that can have very large discrepancy between lesion dose predicted versus actual. But it is an enormous failure of the prediction that should be taken into account, because you can have lower discrepancy, but anyhow very significant. On the contrary, if we consider the normal liver, the difference is much lower. So this is a very important item to be kept in mind when we plan this treatment, that the prevision is much more reliable for the total non-tumoral liver with respect to the lesions. And we do have also a product which is another kind of microspheres labeled with holmium 166, where you can use in the same the simulation phase, you can use a scout dose with the same particles that you use in therapy. And in this paper here, they studied the patient first with macroaggregates labeled with technetium, then with holmium scout dose, low activity pre-therapy simulations, and then they studied the patient in therapy after the treatment with the SPECT-CT. And as you can see here in the blood outband, the confidence interval is narrower for the scout dose performed with the same particles. So with the holmium 166, you have more accurate prediction for lesions than with macro aggregates. And so, but nevertheless, there is always a difference that goes up to 100 gray plus minus for lesions, which is attributable to intrinsic methodology, because you treat a patient after some weeks, and you can have different blood flow, you can have different catheter position, so there is always some discrepancy for lesions between prediction and therapy. And this reinforces the role of the dosimetry to the non-tumoral liver. So let's go to the simplest method for the dose calculation, which is you draw a ROI around the tumor, you draw a ROI around the normal liver, and also around the total normal liver. And here you see a lot of formulas that appears threatening, but they are not, because basically the identity of biodistribution, the so-called hypothesis number 1, is just a proportion that the activity you have in a void during therapy divided the total activity is the counts you have in a void divided the total counts. So this dosimetry is really simple. And you can revert this proportion, and you can write in this way, where you can group these parameters here. And so the activity in a void is proportional to the counts in the void times a conversion factors. These conversion factors is something that is different that was previously mentioned by the previous speaker, because it is determined patient by patient. It is not the conversion factor given by your camera in absolute conversion factor, but it is patient dependent and activity dependent conversion factor. You just determine on each patient, just drawing the total counts void. There is no need of technician activity measurement. And so then recalling that the dose is just given by the activity divided by mass multiplied by a constant, you can write that the dose to tumor is a constant by the conversion factor, by the count in the tumor divided by the mass of the tumor. Similarly for the tumor number 2, and say, etc. And for the whole parenchyma, the same is when you total subtract from total counts the counts for the tumors and the mass for the tumors. So it is really simple mathematics. No need of complicated. You need just an Excel spreadsheet to do this kind of dosimetry. So once you have the absorbed dose predicted, which activity is the best one for the patient? How to plan the treatment? You have, for instance, an Excel spreadsheet where you have 4 columns, and for each column you can compute the dose to the lobe, the therapeutic activity, the vial you have to order, and the activity decayed from the reference time to the injection day. And you can have a lung dose, you can have a mean dose for the lesions, for many lesions. You can have the dose to the whole non-tumoral liver. For this, now starts the job passes to the medical doctors, and the question is, which one shall I choose for this patient? Well, first of all, you have to consider the lung, and if you have a too high lung dose, for instance, here, if you overcome 30 gray, you should not choose the last 2 columns because the limit is 30 gray. So you can choose the first of the second column, so 9 or 10 GBq vial to be ordered. But once you are here, which is the best choice? Shall I consider the lesion dose, or shall I consider the dose to the whole non-tumoral liver? Well, let's go to some trouble we have with lesions. One trouble I showed before. The second trouble we have with lesion is this one. These are from different literature, and you can you can look at the guidelines. There are other mentioned in papers. When you have responding and non-responding lesions, like here or in this plot from our group, you see that the absorbed dose of responding and non-responding lesions are quite overlapped. So it's very difficult to say which is the dose that will give you a response. Unless you go very high, above 500 gray, this is valid for glass spheres, teraspheres. So, but in any case, it is very difficult to say if a tumor will respond or not. And this is true also with post-therapy imaging, like you see here in this left plot by the group of Texas. So it's very difficult to say in advance if a tumor will respond or not, or even after the PET confirmation, PET dosimetry post-therapy. And then we can consider this publication from my group, where we considered the total liver dose. And we saw that if you go too high with the dose to total liver, you produce a so-called treatment related liver decompensation. Basically, you destroy the organ, which is a vital organ. A patient has a very bad prognosis because the survival drops to 6.5 months versus the 16 months of the whole cohort we studied. So very significant problem. So radioembolization can shorten the patient life, and this must be known because companies, they never say this, they never wrote this, but with radioembolization you can kill patient, and this is the unique case in nuclear medicine therapy where you can kill patient with only one therapy. So it's very careful choice of activity. So treatment-related liver decompensation must be avoided or maintained low because you need to treat patients. And we studied this problem. So let's put together the ideas. Lesion dose, we have inaccurate prediction by technician many times. We have, even after therapy with accurate yttrium-90 PET dosimetry, largely overlapping those intervals. We have on the other side, considering the normal liver, that the prediction is much more accurate. So the proposed method is to aim at the maximum tolerable dose averaged over the whole non-tumoral liver, including the non-injected lobe. This because the mean dose to the total liver, from the radiobiological point of view, is the first predictor of liver toxicity, because liver is a parallel organ. And we studied patients, and we saw that the basal bilirubin is a severe risk factors with an odd ratio which is 6. So patients with bilirubin higher than 1.1 have a risk 6 times higher of having the liver decompensation than patients with low bilirubin levels. And here you see, depending on the absorbed dose, how the risk increases. If you have a low bilirubin level, you have a low curve, a low risk, and you can go up to 90 gray to the whole non-tumoral liver, while if you are at a high bilirubin level, you have a very high risk, increasing steeply, more steeper, and you have to stay below 50 grays to the total non-tumoral liver. This is the limits that are applied currently in my centers, and you can have this, the publication describing in detail all our results. And finally, this is a very important slide for the radioembolizations, because this is a study by Etienne Guerin and the group in France, where they applied personalized dosimetry aiming to high tumor absorbed dose, 200, more than 200 gray to tumors, even 300 if possible, and they divided the patient in 2 groups. The standard dosimetry group with glass spheres, where they computed 120 gray to the normal liver, which is the standard indication for TeraSpheres. On the other group, they treated the patient after personalized dosimetry, giving 250 or 300 gray if possible, considering the dose to the non-tumoral liver as a safety limit. And as you can see in the 2 populations, the patient treated after personalized dosimetry are represented here in blue. They showed an overall survival of 26.7 months versus only 10 months with the standard approach. And so it is this was a randomized study, prospective. It is the first undebatable victory of dosimetry, which demonstrates that 2-compartment dosimetry, when you compute dosimetry to the tumor, dosimetry to the non-tumoral liver, and you give the maximum dose to the tumor possible within the safety limits, you can increase survival more than 2 times. So this is a very first demonstration that dosimetry can have a large impact on patient survival in this class of patient. And since dosimetry won in this case with microspheres, I think that it should also win with all the other radiopharmaceuticals. And let's go to other pharmaceutical. Iodine and lutetium, I will say they are 2 cousin isotopes because they have very similar long half-life, they have similar beta energy and similar range in tissue, fraction of millimeters. The difference is the photon energy and abundance, because with iodine we have high energy with a high percentage of emission. With lutetium we have medium energy with the low percentage of emission. And from our point of view of dosimetry, this is a point that when we make dosimetry with iodine, we can have problem of detector saturation after therapy, while we don't have any problem of detector saturation, of only reduced problems if we scan a patient just 1 hour after administration. But if we wait the day after administration of lutetium agents, we don't have any problem of that time. So pharmaceuticals with lutetium we have on one against the neuroendocrine tumors, but keep in mind that these are rare tumors, so we have few patients, and these patients, this pharmaceutical were approved after the NETTER-1 phase 3 study. The pharmaceutical name is Lutathera, where if you compare the progression-free survival, so the interval without disease after the therapy, at 20 months, patient having no progression were 65% if treated with lutetium Lutathera, or versus 10 or 11% if you were treated without the radioactive isotope. So this was the registration study, and now we can use from 2019 this agent in our therapy facilities. We are waiting for the PSMA pharmaceutical, which is just used only for compassionate use. But keep in mind that the prostate cancer is the most common male tumor, so we foresee a lot of patients, not so few as the neuroendocrine. And this the Vision phase 3 study confirmed that PSMA can prolong the progression-free survival from 3.4 months to 8.7 months, and the overall survival from 11 months to 15 months. But keep in mind that there are studies that patients with prostate cancer, if the metastases are not in the bone, you can completely cure the patient and go to no evidence of disease. So for prostate cancer, PSMA could be really a miracle treatment for patients having no bone metastasis. Let's go to the neuroendocrine tumor that often express this somatostatin receptors on their membrane, these green receptors here on the cell membrane. And you can use this molecule that target these receptors, that goes to this receptor. And these are small molecules with a fast renal clearance because they are small, much smaller than the antibodies. And the first one was the octreotide. The commercial name was the Octroscan, that was used for diagnostics. But these are all designed to be analog to this somatostatin that is produced even by our body and goes to moderate the growth of the cells. So just for physicists that are often confused by these molecules, we have the octreotide, is the old one. And then we have two kinds of molecules that are a small variation, but changing this green amino acid here with another amino acid. We have the TOC and the TATE. So that's quite similar, and they go to the same receptors. And then we have the chelator. The chelator is the link. It is the tweezer that links the molecule, the carrier, to the radioactive isotopes in red here. So with the Octroscan, we had the DTPA, and now with the modern molecule, we have the DOTA, which is more efficient because it's a ring that traps the radioactive isotope inside. And so we have, for instance, the 170 lutetium DOTA TATE, which is this molecule, which is the commercial Lutathera, that have an approved posology for 4 times 7.4 gigabecquerels with an 8 weeks interval. With this radiopharmaceutical, which are the organ at risk, and which the kind of toxicity, we have the bone marrow as all the treatment in nuclear medicine, and it is mild and reversible toxicity, except in some patients. This seems the limited toxicity for this treatment, but unfortunately, dosimetry has still not found a proper way to correlate with the toxicity observed. So the dose toxicity is still, correlation is still unclear. And my personal opinion is that the image-based dosimetry should be used here. So you have to do a SPECT on and consider the 3 lumbar vertebrae, L2, L3, L4, and draw a region of interest in that region to compute the dose from that void. Then we have the kidney. Kidney, in principle, could be a critical organ. Actually, it was a critical organ, but in the past, when this molecule was labeled with yttrium-90, but yttrium-90 has a much higher energy beta, much longer range, much more uniform irradiation of the kidney. So in the present use of lutetium, we don't see any renal toxicity except caused by the disease itself. So patient having already renal insufficiency And so this is actually considered an organ that should be evaluated with dosimetry, but we don't have actual toxicity, at least if we stay up to 4 administrations. And then we have also the pituitary gland, the hypophysis, that in principle can be a critical organ, but with the present schedule, it was never observed to have a damage. For the prostate cancer PSMA, the posology is similar, except that we can have 4 or 6 administration, and PSHAM accumulates, as you can see in this image here, in prostate metastasis, but of course also in salivary gland that are parotid glands and submandibular glands, and in lacrimal glands. So these glands are organ at risk because if you destroy the salivary gland, if you go to this xerostomia, you can have a very bad quality of life for a patient. So dosimetry should prevent this effect, but we are not able still to say which is the threshold of the dose to avoid the salivary gland toxicity. For the tumor, we have 2 papers. This is the most famous, where the dose response curve is shown, and it is very nice correlation between tumor absorbed dose and response given in terms of RECIST parameters, so reduction of the tumor diameter. And you see here that the threshold for RECIST 1.1 is a reduction of 30%, and this is reached if you deliver more than 150 gray to your neuroendocrine tumors. So we have an idea, and we can predict with dosimetry if a patient will be cured or not with this kind of treatment. So we have the recently published the guideline by ENM, where you can do dosimetry for neuroendocrine, and we have also a bit older pamphlet published by the European people and the American. We worked together with the Americans for this. And the first note here is that for dosimetry of lutetium, you keep only the 208 peak, the higher energy peak, to avoid the high scatter contamination you have in the low energy peak. You have to apply scatter correction, you have to use medium energy collimator, matrix 128, and you have to acquire the spectrum with the 5 degrees or 6 degrees, not 3 degrees is useless. And for the quantification, of course, you have to calibrate your systems. And for imaging, normally, there is still some group publishing with planar dosimetry, but with neuroendocrine, you have a lot of activity going in the intestine, and intestine overlaps with liver, with kidney, so you have difficulty in subtracting the overlapping activity, and the SPECT-CT is, of course, the best way of doing dosimetry nowadays. You have to calibrate your system, and here, depending on the model you have, on the brand, the General Electric, they suggest to calibrate with an activity you prepare in a geometry. For Siemens, you have two kind of calibration. You can use a cheaper blood quantification software, which is a periodical calibration with a point source and a one forever calibration with a cylindrical source filled with lutetium, or you can have the expensive X-Quant package, which costs something around $40,000 per each isotope, which is based for lutetium on a certified source, which is also expensive, and you have to change every year. But this provides you a certified NIST traceable calibration, which means that you calibrate your system versus an activity which is measured by the producer, and all the system in the world have the same calibration reference. This is very nice, for the first time available with this kind of brand. partial volume effect in lutetium dosimetry must be corrected because the spatial resolution is lower than PET, and we have often small lesions. So we have, for instance, this is 37 millimeter spheres, diameter spheres. It is already affected by partial volume, and my suggestion is that you put these spheres in water and you add a large bottle. You take a mineral water bottle, half-liter water filled with the same concentration of the spheres, and you take this one as reference to compute how much is the loss due to the partial volume effect. In the reconstruction, please don't use the clinical reconstruction, but use the dosimetric reconstruction, which is based on absence of Gaussian filter and high number of iteration as subset to have a reduced partial volume effect and to go for the highest spatial resolution. Usually, I suggest something around 8 iteration and 8 subsets, or 80 iteration, 6 subsets. This you can optimize on your scanner and making your imaging. How many scans? Which times? This is quite old paper, but gives the truth that if you want to scan with lutetium, you have to go to late times. You can't stay at two days after injection. So they propose 100 hours, and the fitting method is not so important. The important is to have a late time point. This is another interesting, very, very interesting proposal by the group in Würzburg, Harriet Heinscheid and Michael Lassman, as a physicist, where they made this approximation, which they derived from hyperthyroidism, so the old formulations. And these two factors that in blue square can be approximated with this in red square, where in this red square you have the time when you take the scan, the small t ref, and the rate in the organ at this time. So this means that the dose to an organ or to a lesion can be estimated with only one time point. And this is the approximation in a plot. You see the blue term is this one with a variation, and the red one is this horizontal line. As you can see, the two are quite good in this interval between 50 hours and 100 hours. So in this interval, you can approximate and you can do only one scan. This is, of course, the goodness of this approximation depends on the effective half-life in the organ you are looking at. And if you look at a kidney, normally a scan at 48 hours could be okay, but if you go for lesions where they have longer half-life, effective half-life, you should scan to longer time. So 96 hours is proposed as the best compromise. So you inject Monday and you scan the patient Friday. This is the proposal by this group. There is the group in Sweden by the oncologist is Hanna Lundroth, but the physicist is Katarina Sjogren-Gleisner, working in Lund, and they made a dosimetry with 1, 2, 3, 5, 4, 5 time points planar plus 1 SPECT-CT at 24 hours, and then they computed many other dosimetry, changing the point and removing one of these points with respect to their gold standard. And the conclusion of the event, so they had a lot of methods, method A, B, C, D, E, changing this time of the scans. And if you go here and look at the Blanda-Altman plot, so the difference between the gold standard and the method A, B, C, D, you say that the method G is the more accurate, where you reach 11% difference with 2 standard deviation, and this is the method of a SPECT-CT at 96 hours. So this still confirms the fact that one tomoscan can be a good predictor for dosimetry with a confidence interval of 11%. How many scans or which times? This is still an open question, because if you look at the guidelines, there is no definitive answer. So the guideline says 3 scans the late one after day 7 or later. Hansched says 1 late scans. I can say that in my centers, we perform 2 SPECT CT scans, 1 the day after the injection, just before the patient release, and 1 at day 7. And we have a study on 7 patients showing that the approximation is quite good. Then we go for the dose calculations. So the use of S factors. S factors can be found, of course, in the commercial program Olinda version 1 or 2. You can find in this program, which is free online, the IDAC dose, or in this website OpenDose, which is created by the group of Professor Manuel Batllés, which I suggest you go to this website because it's rich of a lot of information. Here we have that with lutation, we have a low photon abundance and not so high energy. So for dosimetry, only the beta energy can be considered and only the self-irradiation. So this is what I call the photon-free dosimetry. And if you go for this, we have a 2% accuracy. This means that you have to compute only the source organ absorbed dose, and this is valid for masses from 2 grams to 300 grams for simple convex shapes, not for red marrow. So the S factors is given by the energy emitted per decay by the electrons divided by the mass of the organ, so by the mass of the kidney, for instance. And this is extremely important that you must use the mass of the kidney of each patient. So the mass of the kidney must be contoured on the CT and introduced in this calculation. The last ingredient in this framework for lutetium is the BED, biological effective dose, because only with the linear quadratic model in this paper they were able to explain the toxicity. So I just go fast here because time is passing very, very fast. Clinical implications. In this study, they studied patients giving to kidney the maximum absorbed dose possible, and they found that patient can reach not 4 administration, but 8 administration without kidney toxicity. And I know that they are producing also the clinical paper for these patients, so be in alert for the publication of this paper. And in this other group in Sweden, they have compared the outcome of patient where dosimetry, where administration was stopped for reasons earlier, or they give the maximum dose to kidney, and you see that in patients where they maximized the number of administration, the overall survival was almost 2 times than the patient where they gave a lower number of administrations. So we can go beyond 4 administrations, and this is a huge increase in efficacy. But unfortunately, is this allowed? Unfortunately, administering more than 4 times is not allowed by the law, because we have an instruction by the company, a registration study, and so by paradox, there is a conflict between the legislation of pharmaceutical that says 4 administration only, and there is the legislation of radiation therapy that says you must optimize the absorbed dose to tumor and non-tumoral region. So there is a study now promoted by the European Union to clarify the legal conflict between these 2 legislations. In IAEA 131, the medical physicist is much happier because we have no posology, so we can deliver whatever we want. And this is stated in this document from the Italian Nuclear Medicine Association and Medical Physics Association, an agreement document which was presented to our health ministry as a guidance for the new legislations. And here you see the table says that for differentiated thyroid cancer, the recommendation for dosimetry before treatment is not for remnant ablation, is not for nodes in the neck, it is for patients with distant metastasis, or for pediatric patients, or for patients with special situations. So dosimetry is recommended for distant metastasis before the first radioiodine therapy, because after the first radioiodine therapy, lesions are severely stunned and efficacy is lost in the sequence of therapeutic administration, as you can see later. We can have 2 approaches. We can maximize the activity, delivering 2 gray to the blood, making just the blood dosimetry without imaging. We need just blood samples or and whole body count, or we need optimization. We have a balance between those to the metastasis and those to the blood, and we should aim to 80 gray to the soft tissue lesions and 400 gray to bone lesions. So in this guideline that was published in 2009, and I worked also on this, you have the formula to compute the blood dose, and you have to compute the full body retention with the uptake probe and the patient standing at least at 2 meters. We have to take blood samples in this way, and this is the framework. But basically, you take in Milan, we take 4 blood samples and 4 whole body counts in the first, second, and 5th days. And this approach was already available in the 60s and applied in the Memorial Sloan Kettering, and they reached 29 gigabecquerel, which is 800 millicurie of iodine in a single administration. And they never had problem because they made the dosimetry and they gave the highest dose to patients that tolerated more. And also recently in Würzburg, they made a study in this way, and they saw that this is very safe, and this is the hemochrome profile. So you have an nadir at 1 month, which is low, but then there is a spontaneous recovery. And they saw also a thyroglobulin response in 12 patients over 13. So maximization seems also to be effective. But this is a very, very important paper by a Korean group in Seoul. They studied 47 patients that were refractory to iodine after repeated administration of standard activity, let's say 200 millicurie, the 43 papillary, 4 follicular. They made the 2 gray approach to the blood, and they studied response, complete response with thyroglobulin, scintigram, and radiology, and they gave in each cycle 340 millicurie, and they repeated this maximization 4 times, but even in 6 times to this patient, reaching 1.5 curie to some patient in cumulative. And the result was that patients that were refractory to the standard 200 millicurie, they become responders. In half of them become responder with complete response in red and partial response in green in this pie graph, with limited toxicity, transient spontaneous recovery in most of patients having toxicity, and only 3 permanent and only 1 G4 hemochrome toxicity. So this is very important paper. The second very important paper comes from Klubo, Gwidzinska, and a Van Nostrand group in Washington, where they studied patients injected in one hospital.
Good afternoon. After the short break, we are just before the last lecture for today. Unfortunately, the presentation of Carlo Chiesa was broken almost at the end of his presentation. So after the presentation lecture of Margarita Kirienko, we will ask Carlo to finish his presentation. So I would like to ask Margarita Kirienko, who is expert in nuclear medicine at National Cancer Institute Milano, and the presentation and the lecture is entitled State of the Art and Future Developments of Artificial Intelligence Application Nuclear Medicine. Margarita, the screen is yours. No, we don't hear you.
Can you hear me?
Yes, great. Now that's
fantastic. So thank you for the kind invitation. It's really an honor for me, and I would like to share with you our vision and the opportunities on artificial intelligence in nuclear medicine. Disciplines using radioactive sources is moving toward automated systems and approaches capable of assisting and supporting medical decisions. Fewer are facing clinical arena, but more is expected in the near future according to preliminary research. So my presentation will deal with some definitions of the artificial intelligence field, then some focus on network architectures, then technical applications and some clinical ones, and also finally the challenges that we are facing in artificial intelligence applications development, which synergies are already existing, and future developments. Before starting, I would like to focus on the rationale of using artificial intelligence in nuclear medicine. Obviously, we have to address the unmet clinical needs in order to personalize patient management. Though we need biomarkers, which are defined as measurable and quantifiable biological parameters, which serve as indices for health and physiology, and also radiographic parameters are biomarkers, which have the advantage of being non-invasive, can assess whole tumor, multiple lesions, can be repeated, and therefore it is cost-effective. Additionally, artificial intelligence applications are expected to alleviate medical workload and also physicians, which collaborate with us, and also to enhance quality. So imaging biomarkers are non-invasive, since radiopharmaceutical injection is a almost non-invasive procedure. We can assess the whole volume of the tumor. Then we also can visualize multiple lesions with our whole body scans. The images can be performed, and we can also compare our findings from the baseline to the end of treatment. And also, it is a cost-effective application, since we use images acquired routinely in our clinical practice. So, quantification in nuclear medicine, starting from the very simple quantifications which has been described this morning. The advent of radiomics and AI are just a further step in complexity to describe tracer uptake. So, coming to the terms and concepts of AI, I will briefly introduce the main definitions to provide a common ground for the audience. So, AI is a discipline that studies intelligent agents, which is any device that perceives its environment and acts to maximize its chance of successfully achieving its goals. AI was founded as an academic discipline in 1955, and AI applications aimed reasoning, knowledge representation, planning, learning, natural language processing, perception, and the ability to move and manipulate objects. Machine learning is considered a subfield of AI. Machine learning algorithms build a mathematical model based on sample training. The models improve automatically through the experience without being explicitly programmed. Deep learning is part of the machine learning methods based on artificial intelligence networks, which are characterized by multiple layers in the network. So deep learning architectures include deep learning neural networks, deep belief networks, recurrent neural networks, and convolutional neural networks. The development of an algorithm can be performed using different approaches. For simplicity, I will report the main two, which are the supervised learning and the unsupervised learning. For supervised learning, example inputs get labeled with the desired outputs and are presented to the algorithm. The goal is to learn a general rule that maps the inputs to the outputs. The import function can be used for mapping new examples, for example, also the test data, to verify its performance. The ultimate objective is to develop an algorithm that correctly determines the class labels for unseen cases. While for the unsupervised learning, the algorithm is given the inputs without the corresponding labels. So the learning algorithms on its own should find structure in the input data. Unsupervised learning can be aimed at discovering hidden patterns of feature learning. So these two approaches can be used for different tasks, so which are classification, regression, clustering. When we talk about classification, we have to approximate a function from the input variables to a discrete output, while regression is aimed at estimating the relationship between one dependent variable and one of a series of other independent variables, while clustering is aimed at discovering grouping in data. Different kinds of algorithms can be used for all these tasks, and neural networks can contribute to all of this. A neural network is a structure that relies. Sorry, I have some problems with the audio. Sorry. Neural networks are computing systems that are based on connected units or nodes, and each node can transmit the signal to the another one. This signal at a connection is a real number, and the output of each neuron is computed by a nonlinear function, which is the sum of the inputs. However, the signal has a weight that increases or decreases the strength of the signal, and the nodes are generally generally aggregated into layers. Different layers may perform different transformations on their inputs. So the learning comprises adjusting the weights. For processing images, the most successful architecture are the convolutional neural networks. In fact, these have become dominant in the field. The convolution operations are linear applications of a filter kernel to local neighborhoods of points of an input. And while the other operation, which is combined to the convolutions, are the pooling operations or downsampling. And it groups feature map activations into a lower resolution feature map. Consequently, when we train an algorithm, the development consists of selection of the hyperparameters, training and validation, and then testing. Training consists of the adaptation of the network, so adjusting the weights and the thresholds to better handle a task by considering sample observations. Initially, the weights for each artificial neuron are randomly chosen. Then they are adjusted at each iteration, targeting minimization of the loss function, which quantifies how close the prediction is to the target. Learning is complete when the observers are at the minimum. The images modalities can be used as input to these algorithms are all those that you could imagine. So as in this image, the ultrasound, also pathology images, CT, and also nuclear medicine images as the thyroid scan in this slide. And the convolutional networks can be used with different purposes. We can perform a classification or also a clustering. The artificial intelligence applications have been also used for the so-called computer-aided diagnosis systems, which can be based on different approaches. We have the machine learning relying techniques which use predefined features that are extracted from a region of interest by an operator, and the most robust features then are fed into the classifiers. And on the other hand, we have the deep learning techniques that do not require definition by human experts, and they extract features automatically to provide an output. So to summarize the main concepts, machine learning algorithms build a mathematical model, and the deep learning is based on artificial neural networks with multiple layers. The convolution operations use images as inputs, and the training consists of adjusting the parameters, the weights and biases, of each node until the minimum error is achieved. Neural networks are used for supervised and unsupervised learning, and the computer-assisted diagnosis are based or on machine learning, classical algorithms, we can call them so, or deep learning. So, coming to the network architectures. These are can be different according to the weights, the topology, and from a decade, several proposals have been made, and they gained a lot of success. Indeed, the publications in the last decade have grown exponentially. So from the AlexNet, I will not go into details with all these architectures, but just to make you realize that the evolution is related to the growing complexity of these layers. So from the AlexNet to the VGG, we have doubled the convolutions in the architecture. Here we see the inception architectures where we can see the concept of the network in the network with the growing implementation of blocks within networks, and then several combinations of networks within these algorithms, which allow higher performance in the tasks for which these architectures and these networks are developed. And this is one of the last published, and here we can see that 32 towers per each block is used, so very deep network. While the UNet, which takes its name from the shape of the scheme of this network, is a network that have been developed for segmentation initially, and it uses combined the pooling, which reduces the size, but we have also an upsampling that allows high performance of this network in the segmentation task. We have also the generative algorithms that combine two kinds of networks, a generator and a discriminator. And this kind of algorithms have been developed for unsupervised tasks. We have basically random input to the generator network that is aimed at producing the so-called fake images, and the discriminator network has to judge if these images, fake images, are real or not. This provides the feedback to the generator network to provide at each iteration images as possible, similar to the real ones as possible. And different architectures have been obviously developed for different purposes, but it is not still defined which is the perfect architecture for each task. And basically, networks initially have been developed for image classification, and first UNet has been proposed to segment images, while generative adversarial networks have been used for image reconstruction, quality enhancement, and also segmentation. So to sum up this part, we can say that deep neural networks have a larger model capacity and stronger generalization capability compared to classical machine learning methods and shallow neural networks. And the deep models that are trained on large-scale databases achieve outstanding performances, which are close to the human capabilities. Coming to the technical applications, we can say that they are mainly focused on attenuation, maps, and scatter correction for both PET and SPECT imaging. They are also aimed at improvement of image quality, and they also can be used to estimate, for example, full dose PET images from the low dose scans, which even could allow also shorter acquisition times. In this example, in the neurological applications, the authors developed a convolutional neural network to generate PET attenuation corrected images using deep learning from directly the non-corrected images. So they evaluated the quantification accuracy in 4 different radiopharmaceutical data sets, FDG and also the DOPA and dementia traces, and they used obviously the standard of care CT attenuated corrected images, and they achieved reliable results with difference in measurement with less than 9%. And as for the PET-CT fusion, the Kumar and the colleagues proposed an algorithm to fuse the images in order to highlight and to achieve the better performance in diagnosis, in extracting the most important information from both modalities. So they developed this convolutional neural network that resulted in a significantly higher foreground detection, accuracy, and dye score, so segmentation. And as for image quality, Song and his colleagues developed an algorithm that was able to create images with super resolution PET, since they incorporated high resolution anatomical information based on MRI. And they found that the convolutional neural network outperformed other approaches, and they were able to achieve high performance on both qualitative assessment and also quantitative. So in summary, we see continuous improvement of solutions. They probably will soon be incorporated in our scanners. However, a lot still need to be done, since reconstruction, enhancement, restoration, classification tasks, segmentation, and so on, coupled with multiple imaging modalities and also different disease types and complex tasks that we may imagine to achieve. And so all these challenges should still be addressed. So a lot of work ahead. Coming to the clinical applications, we foresee a lot of applications which are in line with the objectives of nuclear medicine, so both molecular imaging and radionuclide therapy, and the indications of these imaging modalities go to oncology, neurology, cardiology, and also inflammation, to diagnose, to have prognostic predictions, and also for image interpretation. And also as for therapeutic applications, we can use artificial intelligence methodologies for therapy planning, for dose assessment, and also for outcome prediction. In this work, the authors developed an algorithm that could support image interpretations, and they classified whole body scans, FDG PET-CT images, and they were able to develop an algorithm that predicted benign, malignant, and equivocal scans with very high accuracy. And this algorithm could be helpful for physicians for double checking while they report their findings. In neurology, the cognitive dysfunction have been investigated in two cohorts, the Parkinson's disease patients and the Alzheimer's disease patients, and they were able to develop an algorithm that was transferable from one cohort to the other, and they found an error under the curve differentiating Alzheimer's disease from normal controls with high accuracy, while the transfer model from one disease to the other could differentiate mild cognitive impairment who would convert to Alzheimer's disease or Parkinson's disease with dementia with very good performance. And the algorithm was also able, as we can see in the figures, to identify the areas which were seen as responsible for judging the diagnosis and predicting the diagnosis of the patients. And also in myocardial perfusion imaging, we can use artificial intelligence algorithms. In this study, in the deep learning threshold set of the same specificity as the total perfusion deficit, so setting the bar equivalently for the two approaches, the per patient and per vessel sensitivity and the area under the curve was higher for the deep learning model, and in predicting coronary vessel damage. While as for the radionuclide treatment, few data are available, and however, in this review by Brochlands and colleagues, the authors foresee several applications for AI in this field, in the theranostic approach, since artificial intelligence algorithm can help us at different steps in radionuclide treatment. In this segmentation of organs and tumors, which is the most consuming task, can be performed using AI algorithms. We can also use AI to predict outcome, and we can also have a PET-based dose prediction, which could make dosimetry probably a clinically routine task. Indeed, in this publication, in this work, the authors estimated the dose for personalized internal dosimetry. So both PET and CT images were used as inputs for the convolutional neural network, and the ground truth was the Monte Carlo calculations. The convolutional neural network-based dosimetry showed improvements compared to the conventional approaches, and they showed to be very close to the reference standard. So to summarize the clinical application, we can say that AI-based image evaluation can identify complex imaging patterns, even maybe not even accessible by the humans, and also advancements of AI can make dosimetry a feasible task in the clinical setting. So we can use AI to image quantification, registration, segmentation for the biodistribution modeling, and also for the calculations. And the predictive modeling of the therapy outcome and the sobredoses will can assist in treatment planning for the benefit of our patients. Obviously, all these opportunities do not come without challenges, and we can summarize them, see with different levels of specificity. We can identify the challenges which are shared within other fields than the medical one, those shared with the health area and the nuclear medicine specific. So coming to those shared with other fields, data is always a challenge, since large, harmonized and structured data have to be collected to be used for the training of artificial intelligence algorithms. These data have to be interoperable and also annotated for the supervised tasks. In medical field, the data have to be also privacy compliant, which is not that easy, since the regulations are very strict in this field. And data have to be inclusive, which means that they have to be representative of the population and not to be biased because of underrepresentations of some categories of patients. Coming to the synergies, several European initiatives are already in place. In particular, Emission, Cancer, Digital Europe calls are available to address these needs. And also as for standardization in data collection and acquirement, the ENM standardization initiatives are ongoing. As for the reliability of the algorithms and their explainability, research is needed to identify the most robust architectures and solutions, and high performance computing is needed to cope with the high amount of data. Also, publication transparency would allow a reliable AI algorithms, which are usually seen as black boxes. So we have to understand how these methods work and how can we trust them. Another point is the intellectual property and the code publication when these solutions come to the commercial. And synergies can be seen with regard to the research with the Horizon Health initiatives. And on the other hand, for the transparency, we have the Open Science initiative, which is growing worldwide, which is aimed at sharing data and also codes in order to make available the algorithm for implementation and transfer to other fields. As for digital infrastructure, which is needed to collect all these data and to share them and to combine data from different centers to build combined models and to distribute them among different centers. So hospitals, clinics, and also patient devices should be connected within federated learning platforms However, such a structure is not available at the moment. Some European funded initiatives are ongoing, so we can expect positive outcomes in the near future. As for the approval process and release and updates, as we see, every time we have additional data, we can retrain our algorithm to improve its performance. However, this requires continuous reapproval process. So new work flows are needed also from the regulatory side. And some regulations and laws are under construction, and we can in the future see faster track for these medical devices. As for the challenges in the health area, we see the regulation and the responsibility challenges, the ethical development, the clinical implementation, and also the so-called human-in-the-loop AI. Indeed, we need to know according to which laws and regulations we have to act, since we have to introduce algorithms which we do not have complete control of in the relationship between doctor and the patient. Therefore, new regulations should be provided by the states and or at the European level. Some documents have been already released by the European Commission, but these are not definitive yet. As for the ethical development, we mentioned before the data that need to be representative of all the patient subtypes, all the patient cohorts, and so this also can touch ethical issues and also privacy concerns, and so in this topic, education on also development is of utmost importance. Several scientific community publications are available, as well as ASMIT are planning different initiatives. In clinical implementation is a challenge, since there is no definite path. The collaboration is needed between industry and health providers, and some companies also proposed vendor-neutral platforms for data processing and development. However, different solutions have to be evaluated and proposed before a wide clinical implementation and exploitation. For the human-in-the-loop is intended the role of the human control over the algorithms during development, but also during its clinical use, since humans should have to be involved in its implementation, have to understand when a prediction is a nonsense, or if a bias could exist related to methodological problems or current problems during the evaluation. So European training requirements are changing within the UMS, including also topics on AI and also different initiatives during the ASMIT events. As for the nuclear medicine specific tasks, we also perfectly know that our discipline relies on the use of the radiopharmaceuticals. And here AI can also play a major role, since AI have been demonstrated to be of value in designing pharmaceuticals, which is also valid for radiopharmaceuticals. So a wide field of research should be investigated, and high performance computing will be of use, should be useful to accelerate this research field. Obviously, radionuclides availability is needed to allow innovative drugs to be introduced in the clinics. Some synergies exist from the Euratom, the Cancer Mission calls, and also the PRISMA. As for the biomarkers, we expect the algorithm being able to extrapolate from the images parameters that could be useful for different tasks in different applications in oncology, neurology, cardiology, to be useful for patient management. So it's a matter of research, and also here high performance computer would be of value. As for radiobiology and dosimetry, as we have mentioned before, artificial intelligence algorithm can provide value to this topic, and a lot of research is still needed in this field. Also, technological and structural update is required to advance our field, since the advent of innovative scanners such as the whole body PET scanners that provide a lot of information in, during the acquisition, and also the forthcoming high availability of data coming from the patients treated in our wards require facilities that can collect how amount of data to be submitted to be fed into the algorithms to create. So, to summarize, we need data infrastructure. We have to go further with research projects to address the clinical needs. The collaboration is essential among different roles in our department. So besides physicians, physicists, technicians, we probably have to include also engineers and data scientists in our groups, and obviously education is of utmost importance in this new topic. So we can say that artificial intelligence and high performance computing are expected to improve both workflow and productivity in research and also the clinical work in the near future, and both imaging application and also therapy by novel drug design, image processing development, identification of imaging biomarkers, support in automated image interpretation in order to personalize treatment. And also from the therapeutical side, AI is expected to allow better radiobiology knowledge, therapy personalization, and also dosimetry clinically available in order to provide imaging biomarkers also for the patients we treat. So in conclusion, we can say that AI has the potential to enable nuclear medicine advanced diagnostics and personalized targeted therapies by improving data quality and data processing capabilities, the infrastructure for data storage and sharing, and also for AI implementation across Europe, basic pharmaceutical research, drug design, by radiobiology and by dosimetry. The education is essential for the human-in-the-loop AI and ethical development and adoption. And finally, through the framework that consider legal, industry, health providers, and also citizens' perspective. Here I report some references, since the presentation was very brief, but if someone would like to go more in detail, these could be the references. Thank you.
Margarita, thank you very much for your presentation. And I have one comment only. There is a loop related to human, to a man, in this process of artificial intelligence. Maybe I'm old-fashioned man, but I like to talk with medical doctors, people. But I see that we are just at the beginning of the revolution in image analysis, not only in medicine, but there's very dangerous, in my opinion, when we talk on medicine at this moment, because someone have to have the responsibility for the medical image. This is the very crucial point, and without the regulations on the national or on the international level, I think that we could not proceed. But artificial intelligence is on the horizon. We see it, but only in sunny weather, I think, at this moment. Okay.
Yeah, I agree. A lot of research is still needed, and we have to take full control of what we develop. However, we have to consider these algorithms as mathematical tools that could accelerate and help us in doing what we normally do. It is not something that will substitute our relationship with patients and our ability to manage medical data.
Yes, for sure. I understand that no one ensured us that artificial intelligence could not go further. I mean, to make the decision, clinical decision, without the man. So that's, well, we'll see, but we have no chance to go the other way, I think. Okay, any questions from the audience? Pytania? If not, no hands. I see no hands. I see no messages. Okay, Margarita, thank you very much for your lecture. And
Thank you.
we are going to discussion roundtable on day first. I mean, we try to discuss 3 lectures. I mean, the lecture of John Dixon, quantification of PET and SPECT data. Oh, sorry. Sorry. We have the end of Carlo Chiesa, sorry. Carlo Chiesa presentation, which was broken almost at the end. And Carlo, are you with us? Are you?
Dobrze, to pokażę Państwu. O, świetnie. To jest koniec mojej prezentacji.
Where we had 60 years of experience, but where dosimetry was always debated and never established it as the preference way. We have the two way of using dosimetry. One is to maximize the activity to a patient, and the other one is to give the optimal activity to cure lesions, minimizing toxicity. For the first way, the maximization is very simple. As I told you, 4 blood samples and 4 whole body counting without imaging, just by a probe, by the thyroid probe, with the patient at the distance. And this is very old. It was used in New York since the 1962, and 10 years later, Leeper published that this approach is safe and useful in selecting the maximal single dose, and there were no radiation sickness and leukopenia. And you see here the activity, which ranged from more than 3.7 up to 29.6 gigabecquerel. This is almost 800 millicurie. The safety was confirmed by the Würzburg group in 2010 in this study here, where you see the platelets count of patients treated with the maximum tolerable activity. You have at 1 month a nadir, but then a recovery, spontaneous recovery. And they mention also that 12 patients over 13, they got a biochemical response. But this is a not so known, but very important study, in my opinion, made in Korea, where they took 47 patients that were no responder anymore after 2 or more fixed activity of iodine 131. They were papillary mostly. They treated with hormone withdrawal and usual framework of treatment. But they delivered the maximal activity to the patient, tolerable activity, even with a simplified dosimetry, with 4 blood samples taken at 2, 24, 48, and 72 hours. They defined the response as complete response with a combination of biochemistry, scintigraphy, and radiology, or partial response if they have more than 50% reduction in diameter and thyroglobulin. They delivered to patient 12.5 median gigabecquerel, which is 340 millicurie, but they repeated this high activity administration 4 and up to 6 times, reaching a total accumulated activity of 48 plus minus 23 GBq, which is 1.5 curie plus minus 760. So a huge amount of activity. And they got a very good result, because patients that were not responder anymore at fixed activity became responders almost in 50% of cases, as you can see here. About the toxicity was in a fraction of 62%, but it was transient mostly, with spontaneous recovery of hemochrome counts. Only 3 patients had a permanent hematological toxicity, and only 1 case of G4 toxicity. In this case, again, I remarked that bone metastasis did not respond. There were only 3 cases of bone metastasis, and they did not respond at this additional therapy. But same author remarked that this radio resistance can be induced by the prior treatments. This is another important study, and was done in Washington in 2 hospitals, but the same group. In one hospital, they treated patients with maximal activity after blood dosimetry, and in the other hospital, they treated patients with empiric fixed activity. And the nice result is that in locally advanced disease, which is, I think, neck nodes, because they call locally advanced disease, they found a significant higher complete response in the group treated with dosimetry, more than 30%, while they, at 6 months, while they got only 2 or 3% of response with fixed activity. The other point is that you see here the progression-free survival curves. There is a difference which is non-statistically significant, but we know that this can be due also to the poor casuistics, poor numbers of patients, but it is a promising result. This is another study that was performed in Italy, close to Milan, by the Busto Arsizio Hospital, Lorenzo Bianchi. I participated to their data analysis. And what the message of this table is that we have two patients that were treated repeatedly with high activity after dosimetry. And you see that all the metastases show a very impressive drop in absorbed dose in the sequence of treatment. So for instance, you go from 477 gray to 161 and to 19, about 20 gray. So what is the lecture from these numbers? And all except this metastasis number 3, all these show impressive decrease of absorbed dose to lesion in the second treatment. So this is the message that all lesions show a response, but for this reason, they don't take up iodine anymore in the progression in the repetition of treatment. So the repeated treatment cannot destroy persisting lesions. There is a big importance of the first treatment. And for this reason, in that paper, we proposed the first big shot strategy, which is giving the maximum tolerable activity at the very first treatment, not at the second, at the very first, for what I said. And for this reason, we followed a paradigm developed by the expert of iodine 1 to 4 PET dosimetry, which says that we can have accuracy in dosimetry to lesion even with only 2 PET scans, as shown here at letter D, one at 24 and one at 96 hours. And we started a study based on the fact that the same group confirmed the historical data by Maxon of 1983. They confirmed with iodine 124 PET, and this data says that for a soft tissue metastasis, you should deliver at least 85 gray to have a very high percentage of probability of response, more than 90%. But for bone metastasis, as you can see here, in order to reach high probability of response, you have to go over 650 grays. And this explains why the scientific nuclear medicine community cannot cure. It is very difficult to cure completely, to eradicate bone metastasis with radioiodine. And so our study is focused on soft tissue lesion, and we hope to delivering the highest activity at the first treatment to cure completely the patient in the soft tissue lesions. This is an example of iodine 124 PET image, where you see a patient with a uptake in the remnant here, very clearly a very small spot due to the incredible resolution of PET scanners. And this patient had no uptake in lung lesion, and this was confirmed when we treated with ordinary activity in therapy. We saw the remnant, which is blurred by the poor resolution of the high energy collimators in SPECT, but no uptake was confirmed in the lung. So this is the usefulness of the iodine 124 PET, which is not registered as pharmaceutical. So a lot of troubles, and we spent a lot of time to obtain the permission to inject in patient. But as conclusion, I would say that in microspheres, dosimetry is a must, because we have the evidence of a randomized study that overall survival can be more than doubled with personalized dosimetry administration. For lutetium, the method is not so fixed, but it's available. We know what to measure, but we cannot change the therapeutic schemes because they are fixed by this legislation, which is under discussion, as I told you, at European level. Bone marrow is still to be investigated, and for PSMA, there is the additional attention to the salivary gland. For iodine 131, we know that maximization is easy and safe. We need only 2 scans, and this should be reserved for the Italian community to metastatic patient, but at the first administration. to optimize the therapeutic activity. And of course, in this context, the iodine 124 PET is the best methodology. This is a conclusion of my presentation.
For your presentation, it's too serious but successful. And any questions from the audience? Pytania mogą być po polsku.
Uczestników. Questions can be asked in English. We will translate them. Nie ma.
Carol, I have some, maybe there are comments only. It's very promising information that using individual dose in the treatments in nuclear medicine, you can extend the, just a moment, survival time partly by 2 times. So that's very promising information that implementation of individual dosimetry in therapy, of course, in nuclear medicine, gives us such outstanding results in the treatment. So that's very interesting information. This is because we here in Poland, we are talking on the implementation on dosimetry in routine, and this is, of course, it's ongoing. This is no case to be without the dosimetry, individual dosimetry. Of course, I'm talking on this and in patient. But we are probably at the beginning. You are much farther. You are, if I understood, you are implementing it in routine medical protocols. Am I right?
When we speak about dosimetry, we first have to split the different applications, because we cannot say we implement dosimetry in all the pathologies, in all the treatment. We have to split the different pathologies. So if the audience would like to go in that paper that was published from the Italian Medical Association of Nuclear Medicine and Medical Physics Association, it was a joint document, an agreement, where we identified in which therapy dosimetry has a priority. Because, for instance, as I told you, anytime I spoke with doctors, they told me, don't ask me dosimetry for the remnant ablation, because remnant ablation, we have so many patients, they have very good successful therapy, no toxicity. So dosimetry, it is not useful in that field, not now, not in this period, not in this historical phase. We must go to the most important therapies, most crucial and critical. And the first one is the liver treatment with microspheres, because we have evidence that dosimetry can prolong survival, because we have evidence that a wrong treatment can kill a patient. And so in that field, and third, because it's the easiest dosimetry, because you use just macro aggregates of albumin, which is available to everybody, a 1-spec CT or 1-spec, and you can fuse another CT from radiology, as we did at the beginning, and you can prescribe the best activity for that patient. So that's the easiest and the most impacting. We have evidence. Then I would say iodine therapy for metastatic. I saw many patients lost for disease progression, and I saw that they were treated with the standard activity. Maybe with higher activity, they could have been saved. So I think that metastatic iodine patient, they can be, I hope, and we try to demonstrate with my study, that we can increase the rate of responses. But we have to treat at the first treatment when the cells are most avid of iodine. For lutetium, both pharmaceuticals, we have the problem of legislation that prevent changing the number of administrations. And so we can start dosimetry, we can learn how to do it, we can learn which doses we have, but the data published in clinical trial where they give more than 4 administration of Lutathera, they demonstrated that they prolonged the survival and prolonged the interval without progression. So this is important, and I think also, and this is not from myself, but it is from another big expert in Europe, Glenn Flux from Royal Marsden Hospital in London, that given the price and the cost of the present pharmaceutical, dosimetry should be used also to deliver the therapy only to patients that have a good absorbed dose provision. If the dose is too low, you shouldn't treat the patient because it is useless. You just irradiate the normal tissue, but you don't have any result on the tumor. And this is under development. We don't have data still, but it is a potential application. Spare money of the health system. But also for thyroid, if you can treat a patient with 400, 600 millicurie only one time, you spare money respect to giving him 200 millicurie with 3 hospitalization, 4 hospitalization, having only a stabilization of disease. We hope to give a better quality of therapy and to spare money. This is both goal of dosimetry.
Yes, thank you very much for this information. And the other question is for dealing with your presentation. It's the case of maximization of the first treatment. That's a very interesting question because, as I understood, that the promising treatment in many cases strongly depend on the first exposure, first administered dose. So that's the case.
I think that if you have in your audience some physician, nuclear medicine physician, they can confirm that they treat the patient the first time, they see metastasis, they see the second time, they see again the same metastasis, they treat the third time, they see again the same metastasis. So if the metastasis doesn't disappear after the first treatment, it never disappears later, because the cells becomes stunned. They have a shock, and they doesn't take the iodine anymore as the first time, but they are still tumor present, so they are still active as tumors, and they can regrow and give metastasis in the other side. So as for any tumoral treatment, the idea is that you should blow as much as possible on the first time, and then you see if that was successful. You take one way. Other, if not, you can go for a small activity and repeat it just to stabilize, to give a palliative treatment. But at least the first time, I think we should try to give the maximum, trying to destroy everything we can destroy. This was demonstrated to be safe. Of course, depends on the basal hemochrome counts of the patient, but it was really, I think it was not investigated enough in the history because of the habit of giving 200 millicurie, always 200 millicurie, 250, not more. This was a habit, but was not a scientific approach. It was just an empirical approach to be safe, but not to be effective. So the therapy now is safe, but it is not so effective. And so we can lose patients. We can have patients dying from thyroid cancer, and we can reduce the number of patients lost for thyroid cancer. With very easy method, because you take 4 blood samples and 4 probe uptake. There is no need of imaging. It's very simple. Low activity can be done by any centers.
Yes, for sure. So maximization, it's safe. So
That is safe. It's safe. It's safe.
Idea. Okay, Carlo, thank you very much for your lecture, but stay with us, and we open the general discussion for the first day. May I ask to take a screen for, okay, we're waiting. So all of you may press microphone and camera to be seen here for everyone. Great. And just let's start. John, would you like to say something, or should you awaiting my question, for example?
No, I've got lots of questions to ask the other speakers actually, but I'll hold back for now and let others have a go first.
Okay. It's these 3 lectures here presented today. They are comprehensive information on the nuclear medicine, let's say, because we started with the quantification. I mean, it's there's the most important thing in nuclear medicine because of the complication of the modeling. Years ago, I thought that CT has very sophisticated mathematical quantification, but I see that nuclear medicine is far ahead. So this is very complicated because of relations between organs. As I saw in your presentation, gum chewing, it's a very important thing when you try to make the proper diagnosis, even therapy, for example. And the very good idea is to promote graphical methods versus traditional. I mean, it's in many cases the mathematical apparatus. It's much beyond the abilities of the routine usage. But when you have the colors or the graphics, let's say, it's much better. You see everything. If you have using artificial intelligence, of course, proper images, you may have colors, you may have support of AI, you may have the information of everything, and you may plan the proper dose for the treatment. So that's I see that your free presenters or lecturers give us very comprehensive information on nuclear medicine, new nuclear medicine. So that's I am impressed. And what more? I'm just looking on my notes. Just give me a chance.
Can I come in there? I think quantification and maybe all of the things we're talking about here, they can appear complex, but they're not massively complex. It's a matter of being methodical. That's just good science or good medicine. I think we might be a little bit intimidating today, but actually, if you look at the detail, I think it's very achievable, and I think it's stuff we can grasp and really make work for us. So just want to mention that really.
Yes, but very individual case. So this is, yes, general formulas are very, let's say, they are easy, not very easy. They are easy. But when you take into account the number of organs, when you take into account the individual parameters of some kinetics, so that's completely different situation. Like for X-ray, for example.
Well, we're better than X-ray, so let's just put that out there.
Almost, that's right. But the source is a little bit different.
Mr. President, I would say that it's much more complicated to convince the medical doctor to use dosimetry for therapy than make the dose calculation. So the problem of dosimetry is not technical. The problem of dosimetry is political. And the most complicated thing is to convince the government to reimburse dosimetry. That is an effort that I started in 2012, and it is ongoing now from the medical side, but that is difficult. If we scan the patient 2 times, and if we need the software, if we need the physicist to make dosimetry, we should be paid. That is the real problem of dosimetry. I think that once dosimetry will be reimbursed, it will be done even when it is not necessary, because everybody will go for it. The problem now is the problem of cost. As anything in the life, there is no money for dosimetry, and that is a real pity. But we have to convince that if you spend money for dosimetry, you spare money from another for patient care, because you cure the patient, because you treat better, you have less toxicity. And so that is, I think, a point of view that should be pushed in favor of dosimetry.
Can I follow up there, if that's okay? That with PSMA therapy, I think this is our opportunity, because when we're talking about neuroendocrine tumors or maybe even thyroid cancers, we're talking about small patient populations. When we're talking about prostate cancer, where, as you say, we can make cost efficiencies by doing dosimetry, we can treat the right people. I think our governments then will start standing up and listening to the argument for dosimetry, because they realize that actually it will be better for the patient, but probably financially better for the healthcare organizations as well. That's my view.
Yes, for sure. I took part, a couple of days ago, I took part in a conference on nuclear medicine therapy, and a person who is involved in teletherapy compared the situation in nuclear medicine with dosimetry, because in teletherapy, brachytherapy, there's obvious there's individual dosimetry before the treatment. And he said that years ago, we started on the same level. And at this today, they use in routine manner individual dosimetry for patients. And of course, in nuclear medicine, we have the shortage, for example, in the physicists. And when we try to implement individual dosimetry in nuclear medicine, it must be supported by the staff and, of course, money. This is obvious. So no chance to go step ahead with dosimetry nuclear medicine without the resources, human and money. That's right. But we try, as you see.
Can I ask Margarita a question about artificial intelligence? Is that okay?
Yes, please.
I think that the challenge that there's lots of people trying to do this, but the problem is getting big data. So do you feel governments are doing enough to allow us to collect data across continents, get real big data? Our legislators, are the governments helping us get the right laws in place? And also a kind of a separate question, what do you feel about companies getting involved? Because I think I'd be quite happy to give my doctor my personal information to help the good of the population, but I'm not sure I'd be happy about giving that to Google or Microsoft or whoever else.
Google.
For the first question, yes, this collection of huge amount of data should be somehow managed centrally by government or scientific communities management, since collection of such a high amount of data need shared infrastructure that should be adopted widely across, for example, European centers. So going in the direction of wide adoption of AI technology needs central coordination, and in these days there's an open call for the creation of a digital infrastructure for cancer images, which should allow data sharing and algorithms development in a secure and privacy compliant way, so a sort of a federated learning platform which should allow to connect different centers and provide predictions or whatever for the patients. When it comes to the companies, I think the topic is very much more challenging, since privacy is the central topic at this point. And the moment that I collect the data and I ask for my local ethics committee approval, this is okay, but when the data need to be transferred to companies, patients should be much more actively involved, and probably a different legal framework is needed at this point. And one hypothesis may be that the patient gives consent on the usage of the data, probably in a similar manner as they leave their money in a bank. And then the patient is conscious of sharing his sensitive data with companies, and can take full control of which data a patient is available to share, and so involve in a deeper way in also public, which need to be also educated on these topics to make informed decisions.
Thank you.
Well, that is challenge, really. Artificial intelligence is the challenge because of, for example, ethics. This is, on one hand, there is some benefits using of artificial intelligence, which maybe it's not conscious, but the algorithms will have a lot of information. I hope you succeed, because they are sensitive data, so they are very protected in European Union, on the world, let's say. And the other question is some awareness of patients they serve, because I am not sure if there are some movies, science fiction movies, when a human is going to the machine and asking for something, and the human get the information very the information is given without any doubts. And when you're going to the medical doctor, you have to ask, you have the chance to ask, to discuss with the doctor. And maybe during the discussion, you get some additional information. The doctor get it. But okay, so, in my opinion, we are going this way, and there is no chance to be back and to change the way we are going to artificial intelligence. I hope that's still unconscious, but what will happen, I have no idea. That's right.
As far as I know, artificial intelligence algorithms are very task specific, so it is not scientific movies vision in which a system is able to interpret the whole situation. We submit an input and we can have an output with a certain percent of probability. There is a lot of room for improvement on algorithm reliability and also explainability. So still a lot needs to be done before clinical implementation.
Yeah, I understand, but you were talking on, for example, SUV bias just about 9% CUV. And you were talking on the implementation of artificial intelligence in double checking system. So when we are talking on double checking, always I am thinking on the man. It's one human being checking the other human being. And in this situation, we lost one leg, let's say. So we have the algorithm, whatever it means, and it stays only one person, one human being, who is responsible for the decision. Because you know that the same situation is with the autonomous cars in US. Who is responsible? That's the question. At Microsoft, Tesla, or let's Google in this case, who knows?
Who knows? But at the moment, I think that no company will take the responsibility for algorithm decision, since it's too sensitive, the output and the economic impact of a wrong decision. So the last word will be with the physician in the near future, I suppose.
Yeah.
And I think that in the near future, the algorithms will help us speed up our clinical practice.
That's for sure. Much better is to put into jail a medical doctor, not software. So that's much better. Yes, I understand. Okay. Have you any more questions or comments?
Well, I can say that thinking to my main field, which is dosimetry, this artificial intelligence, I had only one experience with the software for liver dosimetry, and it was able to make an automated segmentation of liver. That is just alone a huge step forward for us, because normally we have to take one slice per slice on the CT and make the manual liver contour. If we have a software, just with a click inside the liver, you have the complete liver volume. That is something that you have to check and you are responsible for. But it's much faster, as Margarita said. So it is very, very, very useful. Or for the co-registration of two specs together, not going to take this file, take the other file, click the program, take the two input data file, save the last file, load the last. So I think that this kind of, easy task for artificial intelligence can be very useful in the immediate future, and can be delivered by the companies that deliver our gamma cameras or SPECT. After all, I think that in the PET there is a segmentation algorithm which is automated. You just click the lesion and it takes the best threshold on the basis of the iterative thresholding. So it is already in our field. It is just how much it is, the quantitative involvement that will increase in the time, but qualitatively we do have already something in our field.
Yes, for sure. But it's still very small piece of what we understood as artificial intelligence. That's yes. There's a brick in this huge building we are expecting to get as artificial intelligence. I understand it that way. Okay. Carlo, any questions? John, Margarita, comments? I would like to, at the end, introduce my co-chair. She is deputy director of our institution, and she's taking the care on all our activities during these 2 days. Okay, I invite you for tomorrow. Of course, I invite you for the whole program. We start at 10 and we finish at 1:30 p.m. of course, tomorrow to discuss all questions. And once again, thank you very much, all of you, especially for lecturers, very brilliant and interesting apple fruit presentations. And I change the language now. I go to Polish.
I'd like to thank all the participants and listeners for being with us today. I do hope that you have benefited a lot from these 3 presentations, which have provided us with very comprehensive information about nuclear medicine, contemporary nuclear medicine. I'd like to invite you for the next day. Tomorrow there will be 2 presentations and then a roundtable discussion. Thank you very much and see you tomorrow at 10.